the interest when it comes to abruptio has to do with the assessment findings. How is the patient going to bleed? What will be the color of the bleed? Is there going to be any pain? And that is where the NCLEX most likely they will ask a lot of questions on that. And so you will have the placenta separating before gestation or before turned. Okay, so if you have the premature separation of the placenta from the uterine wall after 20 weeks of gestation and before the fetus is delivered, the reason why they are saying after 20 weeks is that we know that any kind of delivery that will be done before 20 weeks for the purpose of the English, we know it is what it is abortion. Okay, and the likelihood that the fetus wouldn't survive is very high. But after 20 weeks, we know that it's preterm, and based on the week the delivery will be done, will determine the nature of the prematurity of the fetus or the baby. And so in abruptio, we are looking at the placenta separating before term gestation and after 20 weeks of gestation. The cause of it, you could have pregnancy-induced hypertension, that is preeclampsia being one of the major contributing factor to abruptio. I mean, you can also have something like pressure to the abdomen. Let's say the woman get involved in RT and other stuff that will cause a bit more pressure on the abdomen. It can all lead to abruptio, but most predominantly it's mostly due to pregnancy induced. I think infection can also contribute to that. On assessments, like I said, that is where the interest is most on what kind of bleeding will the patient have. And we should understand that this patient will present with a dark red bleeding. Now, the reason is that the blood or the bleeding will be conceived. And so by the time the bleeding comes out, okay, by the time the bleeding comes out, it will be what comes along with clots, and it will be dark red in nature. Okay, so if the bleeding is high in the uterus or is minimal, there can be absence of invisible bleeding. But most of the times, if there is going to be bleeding, the bleeding is going to be what? It's going to be dark red in nature. And like I said, the reason for the color being that is that the blood stays there for some time, or it stays behind the uterus for some time, and then before the blood comes out. And by the time the blood comes out, clot might have also formed alongside it, and to be dark red in nature. You're going to have uterine pain. There's going to be tenderness, or the patient will present with both tenderness and then uterine pain. There's going to be uterine rigidity. The reason is because of the blood staying behind, and that causes the uterine to or the uterus to become rigid in nature. So there is uterine rigidity. There's going to be severe abdominal pain, and then signs of fetal distress because the fetus will not get the needed oxygenated blood and nutrients as well as a result of the separation of the placenta or the placenta from the uterine wall. So the fetus will go into some form of distress, and then because of the bleeding, the patient is going to show signs of shock. And we know that when there is shock, your vitals are very important. You need to monitor. It's going to be tachycardia, tachypnea, then BP is going to go down. These are things that will tell you that this patient is going into shock together with other assessment findings. So these are the assessment findings you have to know when it comes to placenta abruptio placenta. Then we have the management. You have to manage by monitoring your vitals. Fetal heart rate, we've talked about the fact that the fetus is going to experience some form of distress. So you need to monitor your fetal heart rate. Then you assess for if there is presence of vaginal bleeding, you have to note the color of the blood that is coming. The abdominal pain, you have to assess all those things. And the fundal height, you need to also assess to see as whether there is any form of increment in the fundal height. Then you have to maintain the patient on a bed rest. This patient is bleeding. You don't want, even if the patient is not bleeding, you don't want the patient to get involved in any form of activity that will cause the patient to bleed more or will put more pressure on the abdomen and will lead to more bleeding. So you need to allow the patient to rest. So bed rest is there. You administer your oxygen. IV fluids, the blood products. Because of the bleeding, you might need to replace blood. So you need to give your blood as prescribed. Then you position the client in a Chedelenberg position if that is indicated to decrease the pressure of the fetus and the placenta, or you place the client on a left lateral position. So if with the head of the bed flat, if there is signs of shock occurs, then you monitor for fetal, or you monitor the uterine activity to see if there is any form of uterine rigidity. Then you prepare to deliver the baby as soon as possible. Sometimes if the patient the baby can be, or the fetus can be delivered through through spontaneous vaginal delivery, that will be done. But I think most of the times the patient will go in for emergency cesarean section to be done in order to relieve the distress that the fetus is going through. We also know that we treated DIC, or disseminated intravascular coagulation, the other time. We know one of the risk factors or the contributing factors to DIC is abruptio. So you have to monitor for any signs of DIC. And when there is signs of DIC postpartum, this patient is going to show signs of excessive bleeding. And you have to target the cause of it, and then you treat the DIC as well too. So that is on abruptio. Let's look at placenta previa. So the two go together because of some form of similarities that they might present with, probably from the name. When you hear of the name, you might think they are the same, but they are not the same. So previa, we said that abruptio has to do with the placenta separating prematurely. Okay. However, previa has to do with where the placenta rather is implanted. The placenta is not implanted at the right location. And due to that, this patient tends to bleed, okay, because of the abnormal location or abnormal place where the placenta was implanted. So previa is when you have an improperly implanted placenta in the lower uterine segment near or over the internal cervical os. So the placenta will be implanted at the lower uterine segment near the cervical os. And when that happens, it means that the smallest thing, or if you try to even do V, you are likely going to cause bleeding because of the location where the placenta is located. That is at the entry points of the cervix. That is when you have the placenta getting implanted. So previa has to do with implantation of placenta at the wrong location. The assessment here, it has a sudden onset of painless bright red. So when you want to know the difference between previa and abruptio, you look at the color of the blood that is coming, or the color of the bleeding. We said that in abruptio, the patient will present with dark red because the bleeding will be conceived, or sometimes the blood has to stay for some days before it comes out. But because this one, the implantation is just at the cervical entry or the cervical os, the likelihood of the blood staying there or staying internally isn't there, okay, or isn't possible. So the blood just come out straightforward. So this patient will present with bright red vaginal bleeding. mostly it occurs in the halfway of the pregnancy. Then the uterus will also be soft, relaxed, and non-tender. The reason is also that because you don't have the blood staying in the uterus, or you don't have the blood being conceived. So at the end of the day, the uterus will become soft, relaxed, and non-tender as you compare it with abruptio, where there's going to be uterine rigidity and then tenderness because of the blood staying in there. Then we also have fundal height, which may be more than expected for the gestational age as well too. So we also talked about how to assess how to measure your fundal height and at what gestational age you need to also, the location you should locate the fundus. We also talked about it. So for those who could not take part in that class, you can make reference to the previous one. I think Ima has shared it. So when you go through, you get to understand that aspect too. The interventions for abruptio, sorry, previa, is also that you have to monitor the fetal activity. You have to monitor vital signs of the mother because of the bleeding. You have to monitor the fetal activity, the fetal heart rate, very, very important. We'll go through the various fetal heart rate readings, and then we'll get to know which ones are okay, which ones are abnormal, what are the interventions you do for the abnormal ones. You have to do an ultrasound to confirm the diagnosis for previa, okay? An ultrasound would have to be done to confirm previa. Then we don't do vaginal examination, okay, or vaginal examination or any other action that would stimulate uterine activity are avoided. And so in previa, we don't do vaginal examination because when you do vaginal examination, you're likely going to stimulate uterine activity. And as we said, the location of the placenta is just at the cervical, also the lower uterine segment. So you are likely going to induce the bleeding. So you need to avoid vaginal examination if someone is suspected of having previa. You have to maintain bed rest. The same thing, you don't want any form of pressure on the abdomen. And then you have to either bed rest and then left side lying position. Okay, I always say that in maths, you have to go for your left lateral. Okay, just in few situations where you will need to maybe put the patient in Lamberg, or you raise the head side of the bed in few situations, but most of the time your sideline position is mostly the preferred one, just to relieve the pressure of the uterus from the inferior vena cava and all that, to prevent syncope and those things, and then also to help blood supply to the fetus. You have to monitor for the bleeding. You treat shock if there's shock. Okay, treating shock, you're going to use your IV fluid. You're going to give your blood. Then you give tocolytics as prescribed. So tocolytics are given to suppress what we call uterine activity. Example of a tocolytic will be a mac sulfate. So you give tocolytics to suppress uterine activity in order to prevent any form of bleeding that might occur. Then remember when we're looking at the um antenatal testings and some of the things they will do. We talked about ROGAM, and we said that if the patient is having a rhesus negative, you have to probably give a ROGAM if the patient is having any unusual bleeding. Okay, so in previous to ROGAM might be given depending on the status of the mother. Okay. Then, if bleeding is also heavy, cesarean section may be performed. You complete previa will require cesarean section. Vaginal examination are contraindicated. So that is our take home for previa. I think I've already mentioned it, but it is being repeated here because of how it is, so that we know that if we come across previa and they are asking for whether you have to do vaginal examination or not, you know that it is a red flag, and then you have to flag that off. that you don't do vaginal examination. You will come across it whilst you are doing your case study questions and then your standard loans and your status and all that. Yeah, Madam Tina, your hand is up.
Please, I want to ask, in both cases, is it like it doesn't resolve, so you need to deliver the baby, or especially the abruptio? Is
The
there a situation whereby,
the abruptio. Uh-huh.
uh,
Uh-huh.
is there a situation whereby the baby can be carried to term even if it's abruptio?
No, for abruptio, no, because abruptio, you need to go in and then open up and deliver the baby. The woman might not, I mean, it's not like a preterm labor where you try to suppress the labor,
Mm,
so probably the woman gets to term gestation, or you suppress the labor for some time. But for abruptio, most of the time the the baby will be delivered in about few days when it happens.
okay. So the
Yeah.
previa to the same thing, they
So
have to
the
deliver the
previa would
baby.
depend. So the previa would also depend. Okay. Sometimes the
Okay.
previa, the woman will be asked to probably go home after monitoring for some time. Okay.
Mm,
And then will be asked to prevent any further activities that might put more pressure and then cause further bleeding. I get me.
okay.
But if
Yeah.
it's also continuous, then the baby will also be delivered before term gestation.
Okay. Thank you.
Yeah. Now, is there any further question, clarification, input? Our midwives who are here, come up with your input. Whenever I'm doing maternity, I always want to do it with our midwives because they have the first-hand experience. Okay. Okay, so no one has any other thing to say. Let's go through touch very quickly. Touch is an abbreviation for about how many conditions? There are a number of conditions here that we're going through. And these are conditions that if you are pregnant or if someone is pregnant, the person would have to do everything possible to stay off this infection or these conditions. The reason is that they are teratogenic in nature, and so they affect the growth of the fetus and can even lead to some form of congenital abnormalities. So you need to understand the conditions that comes together to form touch, and you do everything possible to prevent them. You have to understand some of the mode of transmission of them. They are not any, I mean, uh, any huge conditions. We virtually know them, but probably maybe we don't know that these are conditions that if you are pregnant, you need to do everything to protect yourself from them. So the first one is toxoplasmosis, okay? And so if you have toxoplasmosis and then if you are pregnant and then you contract toxoplasmosis or you get toxoplasmosis, the the chances that the fetus is going to be affected is very high. So you have to, as a woman, you need to protect yourself from this condition if you are pregnant. So this is caused by the protozoa, toxoplasmosis gondii. You most of the time get it from eating raw foods. Okay, so raw meats, handling of cat litters of infected cats, you can easily get it from. So if you are pregnant, you have to avoid eating raw meat and also going near or handling cat litters because you might contract this condition from it. The organism can cross the placenta barrier and then leads to some form of miscarriage. It can equally affect the growing fetus and either cause some form of congenital abnormalities. So we should know that when you take the touch, sometimes you'll be doing and you come across the conditions, you have to now put touch down and then you now be putting the conditions attached to it. So the first T in touch stands for toxoplasmosis. And like I said, it is a condition that you need to, an infection where you need to protect yourself from it if you are pregnant. The next O is other infection. So the other infection, it has to do with HIV, syphilis, parvovirus, and Hep B, Western Nile virus, and Zika virus is also part of the conditions. So you need to protect yourself from these conditions as well too, as some of them, or they can also be they can cross the placenta, but some of them, like HIV, we know that during delivery, if care is not taken, there's going to be, missing of placenta, maternal and the fetal blood, and likely if the mother is having HIV, the likelihood that the baby is also going to get it probably through delivery is also high. That is why SVD might not be really encouraged if someone is having HIV. So if you have all these conditions, you have to do everything possible to or if you are pregnant, you have to do everything possible to protect yourself from this condition. Then the R is rubella. That is why if you are pregnant, we have to do the rubella titer to know your status, to see as to whether you are immune against the condition or not. And if you are not, they will wait until you deliver. When you deliver, that is when we give the vaccine. And so when we give the vaccine, you also have to stay for about 1 to 3 months before you can get pregnant. Because after the vaccine, we know that the vaccine is a live vaccine. And so you can't get pregnant, or if you get pregnant whilst you receive the vaccine within the 3 months duration, you are likely going to cause some form of miscarriage or some form of issue with the fetus. So that is why during pregnancy, you have to screen yourself for rubella to see your titer status. So it is teratogenic in the first trimester. The organism crosses the placenta, and then it can also causes congenital defects of the eye, the heart, the brain, and then the ears as well. So the titer status is that if you have less than 1:8, it means that you are not immunized. And then during pregnancy, nothing can be done. So you carry the pregnancy until you deliver, then we give you the vaccine after the delivery. Okay. So you have to always make sure that you are immunized before you get pregnant. Okay. The client should also receive the vaccine, like I said, postpartum. You avoid pregnancy for 1 to 3 months after taking the vaccine. The next alphabet or letter in the touch abbreviation is cytomegalovirus. Okay, so this is a viral infection, which also mostly transmitted through close personal contact. And so if someone has it, you go close to the person, you are alive. So mostly here, if you want to protect yourself, you have to institute contact precautions to protect yourself from contracting cytomegalovirus or the viral infection. The virus also crosses the placenta barrier, as I said. So all that you need to understand that if you are pregnant, you need to protect yourself from cytomegalovirus. Some problem that might arise from it is that it causes low birth weight. There's going to be intrauterine growth restriction. Then there's going to be enlargement of the liver of the fetus, the spleen. Jaundice will happen. It can lead to blindness, hearing loss, and then seizures upon delivery can all okay. So you have to do everything possible. Antiviral medication may be prescribed for severe infection in the pregnant client. So for this, if you are pregnant and you get it, they will give you antiviral medication for treatment. So one thing I want you to understand is that you have to know that contact precaution is used when someone is having cytomegalovirus. I think the last one is herpes. And herpes, one thing I want to make, or one comment I want to make, if you have herpes, active herpes, okay, active herpes, the woman will not be allowed to even go through spontaneous vaginal delivery if you have active, or if the woman is having active herpes viral infection, the woman will not be allowed to go through normal spontaneous vaginal delivery, because during delivery, the likelihood that the baby will pick up the viral infection is very high. So the herpes will affect the external genital area, the vagina and the cervix. It's going to be some form of drainage and then painful vesicles. And so for this, the virus do not really crosses the placenta barrier, but the mode of transmission of the infection to the baby or to the fetus is during delivery. that is when you're going to have the virus being transmitted to the baby during delivery. So that is why I was saying that during active herpes, you don't allow the woman to go through normal spontaneous vaginal delivery. If during pregnancy someone is having, we give the antiviral medication that is aclovil. So aclovil is the medication for it. Or valasa, is it valastaclovir? Okay. I remember those days when I used to do questions a lot. When you get a viral infection and you want to know the medication you use for it, if you don't know, look for the last ending. You see that this one has OVIR. This one too has OV. So this will tell you that this is a viral, a medication to treat, or it's antiviral medication. Okay. So this medication, some of them comes in the form of cream. You need to apply it, or it comes in the form of cream. You have to apply it at the genital area. And the protocol is that if you want to apply this medication, you have to wear gloves. You wear gloves to apply it. Then afterwards, you have to make sure you wash your hands. So hand hygiene is very, very important. That's contact precaution. You need to also institute contact precautions here, because when you touch the area, you are likely also going to pick up the virus from there. So you need to institute contact precautions as well when you are managing the patient for herpes. Again, if someone is also having active herpes infection, the person is not allowed to have sexual intercourse. It is also one thing they also like asking a lot as to whether someone will be allowed to have sexual intercourse during active herpes. I think even in the latent phase of herpes infection, you don't also engage in sexual intercourse. The reason is that even in the latent phase, the the partner is also likely going to pick up the infection. So you need to make sure that you are treating herpes before sexual intercourse will be allowed. So these no vaginal examination are done in the presence of active vaginal herpes. Okay, so like I was saying, if there is active vaginal examination, you don't do vaginal examination, because you are likely also going to cause picked up the infection. You can push, should I say, push the infection in there and all that. So you have to avoid vaginal examination. Herpes can also cause that severe neuro impairment in a newborn. Delivery of the fetus is usually by cesarean birth. So you have to understand that cesarean section will be done in active inactive herpes infection, like I did mention. Strict precautions are necessary to protect the fetus during delivery. You maintain what we call contact precautions for this woman, and then yourself as a nurse, if you are taking care of this patient, you have to institute what we call contact precautions. So that has been the first part of my class for today. So I finished that areas or those areas. We talked about previa, we talked about abruptio, we talked about touch infection. And so I will end it, then we'll go through one or two questions, and then I will move quickly to the next thing we have to talk about. If you have any question, any inputs you want to make, any clarification, you can bring it on board as well.
Sorry, Brother Mingo. What was the medication that you said we can apply again? I didn't catch that bit, please.
Aclovil, okay.
Aciclovir.
Aciclovir, sorry.
Okay. All right.
Yes.
Thank you. Thank you.
Right. All right, so let's see. My questions are not really difficult, as you know. So if you want to answer, you just raise your hand up, and then you just tell me with your rationale. Madam Vivian, you've already gone through the questionnaire. Okay, tell us what you have for us.
No. I want to ask a question, please.
Oh, okay. Go ahead, Madam
Please,
Vivian.
abruptio placenta.
Mhm.
Does it mean for that one, vaginal examination can be done if necessary?
Yes.
Okay, thank
Yes,
you.
if necessary, yes. But for previa, is no go area.
No, yes, okay.
All right. A pregnant client in the first trimester tells the clinic nurse she will be traveling to an area with a known Zika virus outbreak and expresses concern regarding disease transmission, which statement by the nurse is most appropriate? We have, if you experience Zika symptoms, you notify the healthcare provider. Take precautions against mosquito bite throughout the trip. You are not far enough along for the Zika virus to affect your baby. Fourth one is you should consider postponing your trip until after you have the baby. So let's see, what do we have? Okay, people are answering in the comments chat box there. Okay, 4242. Okay, Y4 Y2. Tell us why you're going for your 4, why you're going for your 2. Yeah, no one is ready to talk. You are keeping your rationales to yourself. That's fine. So the 2 is that take precautions against mosquito bite throughout the trip. The fourth one is you should consider postponing your trip until after you have delivered, after you have the baby. So between these two, so we all understand, we all agree that we take the 1 and the 3 out. But if you are here, you think you also go for any of the 2, you can bring it up. Okay. So now we are torn between 2 and the 4. Yeah, Madam Gifty. Hello, Madam Gifty, kindly unmute and then come on board.
It's for because Zika virus can cause congenital anomalies. Yeah. So
you
it's
are
best to postpone it.
okay. So you
And go
also
after.
side with the 4, right?
4, yes, please.
Okay. So our colleague is going for 4. All right. Okay, let's move on. I don't want to waste a lot of time here. I have a lot to talk about, so. All right. So the fourth one is the best education to give to the woman, that the woman will need to postpone the trip, okay, until she has the baby because of some form of developmental issues that can arise if the woman contracts the viral infection.
Please, we are reading the rationale.
Oh, you are reading the rationale. I'm sorry for that. Okay.
That's fine, thank you.
All right. The nurse is caring for a client at 30 weeks gestation who is hospitalized for preeclampsia. By reviewing the client's chart and performing an initial assessment, the nurse notes several abnormal findings. Which findings should the nurse discuss with the healthcare provider immediately? Dark red bleeding, edema of the hands and face, elevated liver enzyme, urine output of 150 ml in 4 hours. We did preeclampsia the last meeting. Okay, so this question is related to that. So if you have your answer, you can bring it on board. We have that red. People are going for 1. Okay. 1. People are going for 1. What do you think is the answer? Come up with your okay. So what do we think is happening in the 1? Okay. That is making us go for the 1. All right. So it's likely an indication of abruptio. So you need to for the other assessment findings, they are expected, okay, like the edema of the face and hands, elevated liver enzyme, Then urine output. I think even this urine output will be normal. If you divide 150 by 4, you are likely going to get between 30 to 50 mil. So per an hour. So that will probably be okay. But the other findings are normal for someone with abruptio, sorry, someone with preeclampsia. So the rationale, just about 20 seconds, then I will move on. Okay. This will be my last question. Though I have a lot of questions, I don't want to waste a lot of time on it. Then we'll move on to the different things. So I would want to cover much for today. That's why. But if you think I'm going a bit faster, just draw my attention. Okay. A nurse on the antepartum unit is caring for a client at 30 weeks gestation who was admitted with the reports of vaginal bleeding. A diagnosis of placenta previa was confirmed by ultrasound. Which of the following should the nurse tell the client to anticipate? Select all that apply. Additional ultrasound around 36 weeks gestation. 2, clearance for sexual activity if bleeding stops. Discharge home if bleeding stops and fetal status is reassuring. Schedule cesarean birth before onset of labor. Weekly vaginal examination to assess for cervical change. Madam Jane, you can come on
Yes,
board.
well, I'll go for 1, 2, 3, and 4.
1, 2, 3, 4.
4.
Okay. All right, that's okay. Are you going to do you have your reasons to add up to it, or you want to tell us
Yes,
that?
so it said, which of the following should the nurse tell the client to anticipate? So if bleeding should stop, then obviously ultrasound should be done to see how the fetus is doing.
Okay.
And then sex is no. So definitely you have to seek clearance before maybe you want to resume sexual activity. So if you have placenta previa, sex is contraindicated. And then if bleeding stops, yes, the mother can be discharged, and then we hold on for maturity of the fetus.
Okay.
And then definitely we will have to also schedule for cesarean section. And so a scheduled CS bed before we wait for onset of labor. So these are my reasons.
Okay. I had a question. I wanted to ask a follow-up question. On your option 2, do you understand that option very well?
Clearance for sexual activity if bleeding stops.
So if bleeding doesn't stop, you have to do.
So sex is contraindicated. Maybe maybe I didn't understand that word.
Yes.
So sex is contraindicated.
So do you still maintain the option?
So that is 1, 1, 3, 4.
I- well, I think there was another hand that the person has dropped it off. Okay. All right.
So that means understanding it is also part of it.
So if you say clearance, it means that the patient can do it too.
Exactly. I get it.
But it's a no-go area. Okay.
Yeah.
It's a no-go area. But if you say clearance, it means that the patient can do it at a point in time. The moment it is noted that patient has a previa, I mean, no sex until delivery. Okay. Yeah, so let's move on. I have quite a number of questions, but like I said, I will want to cover much a lot for today, and so I'll proceed for now. All right, but then if you have any question, if you have any input you want to make with regards to what has been discussed, you can also come up with it before I make progress. So we are going into labor, we're going into birth, we are going into much more into labor, and then we looked at labor issues, we looked at signs of true labor, false labor, and then we'll go through the rest also. So I'll do well to also cover that, and then we'll go through one or two questions on that, and we see what we can do. So labor and birth, I wouldn't worry you guys a lot with this kind of things. These are things just for us to, revise on when it comes to some of the terms with labor, some normal terms we might come across it whilst we are reading our case study questions and all that, which ones we need to be worried about. And then fetal presentations, we know that you can't have a cephalic, you can't have a breech presentation. A cephalic, which is the most common one, the patient will present with the head, and sometimes the patient can come with the vectors, it can come with the face, it can come with the brow or the military position. So depending on which side of the head is coming, will tell you which of the cephalic presentation the fetus is also showing. Like I said, I wouldn't worry you guys much on it. What we all need to understand is that cephalic is normal, is the expected one, and then the woman will be allowed to go through normal spontaneous vaginal delivery if there is no any other issue. Breech presentation, buttocks will come out first. Most of the time, this patient will require cesarean birth for that. Although vaginal birth is also sometimes possible, but to prevent further complication, the woman will be probably go through CS for the baby or cesarean birth for that purpose. Breech presentation also has 4 variation: the full flank area, or you can have full complete or footling. So depending on what is coming, you also know which of the breech presentation is also common with. You can also have shoulder coming, and so fetus will lie in the transverse, or the fetus in a transverse lie, the arm, back, abdomen, or side could present. Mostly these patients will rotate, or the fetus will rotate spontaneously. However, if the fetus doesn't, rotate spontaneously, cesarean birth will also be needed to bring out the fetus. So among these, presentations, we know that cephalic is the best option, and the woman will be allowed to go through normal spontaneous. The other two, the likelihood that cesarean birth will be performed for the woman is high. My next interest here is station. If you are here, you need to understand station very well. So open your eye, open your ears, and then listen to station. I'll try my possible best to explain station, because station is important. I remember if you have what you are using, you come across case studies and they are telling you the fetus is coming, okay. Cervical dilatation is ongoing. However, the fetus still remains up there, and they will tell you that station is negative. If there is a negative station, you know that it is a bad indication. So station, the progress of descent, okay. So station tells you how the presenting part is engaging with the maternal pelvis, okay. How the presenting part is engaging with the maternal pelvis. And so we know that at term gestation, the fetus has to descend, okay, from the zyphnoid process down into the maternal pelvis. And so if the fetus is, so let me use this image to best explain this for us, okay. So let's check on my screen. I'm coming to show you something here. I always want to use this picture to explain it very well. All right, so let me see if I have this here. Very good. So this is what I want to use. Okay, so for those of you who are monitoring on my screen, this is what station is about. So station has to do with the engagement of the presenting part with the maternal pelvis. And we have what we call the ischial spine. The ischial spine is somewhere here, and we call it station 0. Okay, so if you have a fetus or on assessment, it is said that station is 0, then you know that the presenting part has engaged with the ischial spine, and it's a good indication that the fetus is descending well. Now, so as we can see, the fetus has to move up there, down into the pelvis, and we have negative numbers, we have positive numbers. And so we say that if you have negative station, it means that labor isn't progressing as expected, especially if, let's say, you have a cervical dilatation of, let's say, 8 cm or let's say 10 cm, the cervix is fully dilated. And so at that point in time, you expect to even be ready to deliver the baby. However, if at that point the station is not in the positive numbers, then that means that there is something wrong with the descent of the baby, okay, or the fetus. So all that we need to know is that when it comes to station, positive stations are good, and they tells us that labor is progressing or the fetus is descending down into the pelvis. However, if labor keeps progressing or labor keeps going or cervical dilatation keeps increasing, and then we realize that the presentation or the descent is still in the negative zone or is still a negative station, then that means that something also is wrong with the descent, and that is bad. So you need to probably inform the healthcare provider about that. So negative stations are bad. However, from 0 coming down, which are positive stations, are good. So we say that positive station is good and negative station is also bad. So you need to, but depending on how of course, if it's in the early stage of labor, like the first few hours into labor, you expect to see station to be a negative number, or on assessment, or if you do assessment, station will be negative. But if labor keeps going on and then still the station is still negative, then that tells you that labor isn't progressing or the fetus is not descending as expected. So you probably would have to inform the healthcare provider on that for further intervention to be taken. So that is on station and how to interpret station. Yes, Madam Vivian.
Okay, please, I want to find out. So let's say the woman comes and the station is on -4, and after some hours, the station gets to -2 or 1. It's still in the negative, but what do we say about that?
So it also depends on how the cervix has also dilated.
Okay.
Okay. It also has to do with cervical dilatation and effacement. So if at, let's say, station -0 or -2, the woman is 10 cm dilated, it's still not good, because you expect that at 10 cm dilatation, the descent must be in the positive numbers. Are you getting the point I'm making, Madam Vivian?
Yes.
So it has to go with the cervical dilatation. If the cervical dilatation is, let's say, around maybe 7 cm, or let's say 5 cm, and the woman it has descended from, let's say, -4 to 2, then that is fine, because it means that the labor it keeps on going on. I hope you are getting the picture I'm painting.
Yes, yes.
So it has to
So
go
it depends on the dilatation also.
dilatation also. So we use both dilatation, we use the station, and we use effacement. So effacement talks about the thinning of the cervix. As labor progresses, you expect effacement to also progress, or the cervix to also become thin in nature, so that the presenting part can easily maneuver through. So that one too, we use percentages for it. And so if labor is also progressing, you expect the effacement to also increase, okay, or in terms of the percentage. So at a fully dilated cervix, effacement must be 100%. So we have 100% effaced, then we have probably 10 cm dilatation, then a positive station. Then you know that the baby is presenting as expected, or the descent is going on as expected. I hope you are getting the picture I'm painting.
Yes, please. So doesn't mean station is the same as descent.
Yes.
Okay, thank you.
Yeah, you're welcome. So we have a zero station, like I show you the picture. That is when the presenting part is at zero station. That means that it's at the ischial spine, and then from there you move into the positive numbers, and labor will progress. So above the ischial spine is negative or minus station, and then below it is the plus station or the positive station. And I did indicated what the good one is and what the bad one is. So engagements, when you have the widest diameter of the presenting part passing the inlet corresponding to a zero station, so you have the presenting part being engaged with the maternal pelvis, and that is a good indication that labor is progressing. Let's look at signs of true labor and signs of false labor. So we have true labor versus a false labor sign. Now, when it comes to this, what you need to understand is, one, the pain. How does the patient describe the pain to you for a true labor and a false labor? Do the pains, or do the pain causes any form of cervical dilatation? You get to understand that in a true labor pain, the pain comes or goes along with cervical dilatation. Someone said my screen is small. Is it the tests that are small, or is it my screen has become small? And then sometimes some of the tests, I don't know if this is to everyone. Someone has kept in the chat section that my screen is small. Is it to everyone, or I want to confirm this so that person probably will adjust her side to see.
Yes, sir. It looks small to me.
It looks small, then I think it's
Yes,
there.
sir.
Okay, let me see. But the previous one was okay, right? So I think it's the test on the screen. That is why this one has, I mean, a bit more information on it. That is why it has become a bit smaller like that. So I will try to read it so that we all get it. Okay. So we have true labor, and I was saying, the true labor has to do with signs that indicate that labor is actually happening and the woman is likely going to go to bed. So these are some of the things that will help you to know if someone is experiencing what we call preterm labor. So if someone, let's say at 30 weeks gestation, comes to you present with signs of true labor, that is where you need to intervene. Okay, that is why we are also learning this, so that if you meet a question on preterm, you will get to understand why is this question a preterm, or why are we saying that this patient is having preterm labor. So if the woman presents with signs of true labor, then that is what will tell you. So we have contractions may manifest as back pain. Look at where the pain is located. Okay. Back pain in some clients, the contraction will also resemble that of a menstrual cramp, how the pain looks like. Okay. So for these people, if someone is having, okay, you can go ahead. Okay. For those of you who would want to take a shot of it, don't worry, go ahead. But we don't share our slides out. Okay. Because we do recycle it and use it again. But you can take a shot if you want. So you have to know that the pain also is quite intense, looks like that of a menstrual cramp. The contractions are also regular. So for sign, the number one sign of true labor is that contractions are regular, and then the contraction becomes stronger, they last longer, and occur closer together. So you know that as labor progresses, then contractions in terms of the number of time contraction will occur will also become closer. So then it also leads to cervical dilatation and effacement. So we have cervical dilatation and effacement are progressive. So that means that in a true labor, cervical dilation, what you need to know is that when in the initial stage, the patient presents with, let's say, a 3 cm dilation, in a few hours' time, when you go and do your assessment, you should expect that there will be an increment in the cervical dilation. If the cervix remains the same, it means that it wasn't a true labor indication. And then there should be an effacement. And I was saying that effacement is when you have the cervix becoming thin. So thinning of the cervix in preparation for the passage of the presenting part. And that is also moves in terms of percentages. And so probably in the initial stages, the woman, maybe we say that effacement is 60%. As labor progresses, the effacement will increase to 100%. And when it is 100% effaced, then labor is about to set in, or the fetus is just about to come. So you have the fetus usually become engaged in the maternal pelvis and begins to descend. So you see the baby will move from the negative station into the positive station. So we have to look at where the pain is located. The pain is mostly in the back pain. It's there, and then it's also like menstrual cramp. For a forced labor, the forced labor pain, it doesn't lead to any form of cervical dilation. So it doesn't produce cervical dilatation or effacement, and there's no form of descent when it comes to forced labor. Contractions are also irregular and then without progression. So there's no form of, progression in terms of the contraction. We know that contraction, if it's a true labor, contraction will become more regular, it will become stronger and then occur closer together. But for this forced labor sign, if there is contraction, it will be some kind of annoying in nature. It will come once a while. It wouldn't be progressive in nature. And some form of activities also relieve the pain, or it relieves the labor. So in forced labor symptom, when the patient walks or they do some form of activity like change of position and all that, it also helps to relieve the forced labor symptoms the patient is experiencing. In true labors, contractions increases in duration, intensity, and cervical dilation, and that of effacement is also progressive. There's going to be engagement of the descent. However, for a forced labor, contractions are irregular. They do not produce any form of dilation, effacement, or descent as well. So these are what we need to know when it comes to true labor sign. I think for the pain in these people, the pain is mostly in the abdomen and the groin. So the location of the pain is also important. So when you are reading on forced labor and you come across the pain, you have to look at where is the patient saying they are experiencing the pain. Is the pain in the lower back, or is it in the groin? So for a forced labor, the pain is in the groin area and then in the abdomen, and it's very annoying in nature. So that is on true labor and then false labor. Okay. Then we come into fetal monitoring or fetal heart rate monitoring. The various fetal heart rate monitoring, we are coming to go into them. So they will learn how to read fetal monitoring. Someone want me to go back to take a shot. I think this one. Okay, that's okay. So we'll go into the various fetal heart rates. We'll try to learn how to read them. We try to learn how to interpret when we meet, let's say, variable decel, when we meet acceleration. How are we going to know that this is acceleration and all that? So we'll try to see if we can interpret it or for the purpose of the NCLEX. Okay, so we have maternal or fetal monitoring, and these fetal monitorings are very important. We need to know which ones are good, which ones are bad. What are the interventions for variable decel? What are the interventions for, let's say, late decel and all that? We looked at them together here. So we have the fetal monitor, of course, things we need to do before we do fetal monitoring. We need a monitor. The monitor will display the fetal heart rate for you to know. We know that baseline fetal heart rate is what? 110 to 160. So this is the normal baseline fetal heart rate, that if you are monitoring the fetal heart rate and you want to know as to whether the rate is normal or non-normal, you have to compare it with this figure, 110 to 160 beats per minute. Then the device will also tells you the uterine activity, how contractions are occurring. It can equally gives you the frequency, duration, and then intensity of contractions. Then you monitor the fetal heart rate in relation to maternal contractions. Remember when we were doing contraction stress tests and those things, we talked about the fact that you want to know how the fetal heart rate behaves when there is maternal contraction. So that is what this monitor will also help you to know. The periodic patterns we all need to know is that we have fetal bradycardia, like we know the fetal heart rate will be less than 110. Then we have fetal tachycardia, the fetal heart rate will be greater than 160. Then if there is any of these abnormalities, some of the general interventions is that you have to change the client's position. Oxygen will be necessary. Vital signs will be important. You notify the healthcare provider immediately if there is any form of these abnormal fetal heart rates noted on your monitor. Now let's go into the various fetal heart ratings specifically, or the various monitorings you are likely going to get. So we have variability, we have acceleration. These are all English words, okay? And so it's not any technical word that you say that it will be very difficult for you to understand. But variability is when you have a fluctuation in the fetal heart rate or fluctuation in the baseline fetal heart rate. Now, you know that when you are, let's say, if you are born, okay, we want to see that you have a stable heart rate, okay, or your heart rate it's quite stable. But the thing is that if you are in utero, or the fetus, if the fetus is still in the utero, for you to know that the fetus is doing well, the protocol is that, or the thing is that at least there should be some form of fluctuation in the fetal heart rate. However, it shouldn't go above or below the normal range. Okay, so fluctuations, I would say fluctuation itself isn't bad, it is a good indication. So fluctuation in the baseline fetal heart rate, you can have absent or undetected variability, which is considered non-reassuring. Like I was saying, you don't expect the fetal heart rate to stay the same. That is why, so our midwives here can attest to it, that if you check the fetal heart rate, and then let's say in about a few hours time you go to check the fetal heart rate, you are likely going to get some form of fluctuation. Either it will go above what you had first, or it will go below what you had first. and that tells you that the fetus is moving, the fetus is active. If you do your fetal heart rate and then you are not getting any form of variability, it could indicate that the fetus is probably not doing so well. There is maybe some form of fetal hypoxia ongoing, and so you need to inform the healthcare provider. Sometimes you could get some form of absence or decreased viability when the fetus is asleep. Of course, if the fetus is asleep, you don't expect the heart rate to change or the fetal heart rate to change. And that one, it's mostly about 30 minutes because you don't expect the fetus to also sleep like 6 hours. Okay. So a temporal decrease in variability can occur when the fetus is in a sleep state. And the sleep state is mostly not more than 30 minutes. The fetus will be up again for activity. And so when there is fetal activity, you expect the fetal heart rate to also increase or a bit of change in the fetal heart rate. So variability is good. It tells you that the fetal heart rate or the fetus is doing well. So when you have any form of decrease or absent viability or undetected viability, you need to probably inform the healthcare provider on that, or you wait for 30 minutes, do your rate assessment, and if it's still decreased or undetected, you have to inform the healthcare provider on that. Then let's talk about acceleration. So acceleration is also an increase in something. So acceleration is increment, and acceleration is good. Acceleration tells you that the fetus is doing well and the fetus is good, or the state of the fetus is fine. So what kind of acceleration are we looking for? Like I said, every fetus have their own baseline heart rate. So if you have a fetal heart rate, let's say the baseline is 130, and you want to look for acceleration, acceleration will give you an increase in the fetal heart rate for about 15 beats per minute. And when that increment happens, that increment must last for at least 15 seconds, just like what we talked about when you are doing non-stress test. Okay, that you expect an acceleration or an increase in the fetal heart rate to about 15 beats per minute above the baseline. And when that increment happens, it should stay there for at least 15 seconds. So let's take this as if a patient, if a fetus has a baseline of 130 and there is going to be an acceleration, the acceleration of 15 beats will give you 145. Okay, from 130, it has to move to 145, and it should also stay there for at least 15 seconds. When that happens, it tells you that the fetus is also good. It is a reassuring sign. It reflects a responsive, non-acidotic fetus. This usually happens when there is fetal movement. So when the fetus is moving, is engaging with the mother in the uterus, then you know that the fetal heart rate will go up. It's just like when you are going on a jogging or when you are doing some form of exercise, what happens to your heart rate? Your heart rate will go up. And so the same thing applies to the fetus. When the fetus is also, when there is some form of movement, you expect the fetal heart rate to go up. May be non-periodic in nature, or it may be periodic with contractions. It may occur with uterine contraction, vaginal examination, or when there is mouth cord compression, or when the fetus is in a breech presentation. That is when you tend to have the fetus experiencing acceleration. But generally, acceleration is good, like I said, or it's a reassuring fetal heart rate. Now, the next fetal heart rate is LED cell. So LED cell is also fetal heart rates reading where you have the fetal heart rate dropping to, or a decrease in the fetal heart rate, deceleration is decreasing. So early deceleration are decreases in the fetal heart rate below the baseline. So when you have the fetal heart rate dropping below the baseline, however, this drop will produce a drop whereby the fetal heart rate will always stay above 100 beats per minute. Even if there's going to be a drop below the baseline, the fetal heart rate will still stay above 100 beats per minute. Okay, so the rate at the lowest point of the deceleration usually remain greater than 100 beats per minute. When it drops below 100 beats per minute, it's not good. Okay, it is a bad indication. Early decels occur during contractions as the fetal head is passed through the maternal pelvic. So one thing we always say is that early decel means that there is head compression. It means that the head is coming. So when you are monitoring a patient and you get an early decel reading, that should tell you that the presenting part or the head is being engaged with the maternal pelvis. And it also tells you that the baby is also progressing as expected. So that is what produces an early decel when you have the fetal head being pressed against the maternal pelvis or soft tissues, or such as the cervix, and it mostly returns back to the baseline after the contraction. So the drop in the fetal heart rate will return back to the baseline after the contraction has ended. I will show you the tracing, how it looks like. It says that the tracing shows a uniform, it has a uniform appearance. When you look on the monitor or when you look at the tracing, it has a uniform appearance. It also, early decels are not associated with fetal compromise and require no intervention. So like I said, this is also something that tells you that the fetal head is coming or the fetus is descending. So you don't need to do anything for early decel. All that you need to do is to keep on monitoring and then monitor the fetus and see how the fetus is doing. You don't need to do anything. No need to inform the healthcare provider. If you go and inform a healthcare provider that the woman is having an early decel, the person will fight with you. So monitor, keep on monitoring. Then let's go into the abnormal ones. So the abnormal ones, the first one we'll talk about is late decel. So late decel are non-reassuring and it reflects impaired placenta insufficiency or placenta exchange. So we say that late decel is caused by placenta insufficiency. So placenta insufficiency is where you have the placenta not able to function enough, where it has to deliver oxygenated blood, has to remove waste product and all that. That mechanism or that function of the placenta is impaired. So we have uteroplacenta insufficiency, which is the cause of late decel. So this pattern looks similar to early decel, okay? But mostly late decel will occur after contractions. So I will show you a picture of it, how it looks like. Late decel will occur after contractions has taken place. But then early decel and then contraction occur together. So when you look at the pattern, you see that for early deceleration, the early or the drop in the fetal heart rate will occur together with maternal contraction and will return back to the baseline after contraction. But for late decel, the drop in the fetal heart rate will rather happen at the point when contraction has ended. That is when you have the fetal heart rate dropping. Okay. And the fetal heart rate will also drop below 100 beats per minute for late deceleration. You have the degree of decline in the fetal heart rate from the baseline is not related with the amount of uteroplacenta insufficiency. Interventions for late decel include immediate improving of placenta perfusion or placenta blood, and that has to do with positioning the client on the left lateral. So we'll learn about lying, and then if the client has oxytocin ongoing, you stop the oxytocin, you give oxygen, you give IV fluid bolus or you increase the amount of IV fluids, normal saline, Ringer's lactate, you inform the healthcare provider. these are the interventions for someone with what we call late decel. Let's talk about variable decel. And whenever I'm doing this, I always say that variable decel is the most severest form, or when it comes to the various fetal heart rates abnormalities, it is variable decel according to me. And when you read more, you get to understand that in this instance, you could have the fetal heart rate dropping to as low as 60 beats per minute. Okay, as low as 60 beats per minute or 70 beats per minute, the fetal heart rate can drop to that extent. And variable decel also comes, or variable deceleration also happens when there is a restriction with blood flow or flow through the umbilical cord. So when anything that presses, or anything that presses on the umbilical cord will restrict flow through the cord, and that would affect what we call the fetal heart rate, or that will lead to a severe drop in the fetal heart rate, and there's going to be severe fetal hypoxia. The fetus is not going to get the needed oxygen and all that. So we say variable decel is caused by cord compression. Okay, variable decel is caused by cord compression. Remember, I said early decel is caused by what? Head compression. Head compression means that the head is coming and is pressing on the maternal pelvis. However, variable deceleration is caused by cord compression. That means that you have something pressing on the cord, affecting the flow of substances through the cord. And this will produce variable decel do not have a uniform appearance of the early and the late as compared to early and the late decel. I said that late and then early decel on the monitor usually has a uniform, or they have a uniform appearance in nature. But variable decel is erratic when you look at how the reading looks like. It can occur at any point. It doesn't coincide with the contractions. Okay, so it can happen multiple times even during contraction. The shape and the duration, degree and decline of the below the baseline fetal heart rate are variable. These falls and rise abruptly, and then, like I said, it's erratic in nature. The drop in the fetal heart rate and the shape, when you look at it, it's erratic in nature. We have variable decel, also may be non-periodic, occurring at time unrelated with contractions. Baseline fetal heart rates and viability are considered when evaluating the variable decel. You could have a very significant drop in the fetal heart rate to less than 70 beats per minute. And like I was saying, this to me is the most severest form, or in terms of which one is very abnormal. Variable decel is the one, because the fetal heart rate can go as less, or it can go as low as 70 beats per minute, and it can stay there for about 60 seconds before the fetal heart rate will return to the baseline as well. If this occurs, what you need to do is to identify if there is any form of oxytocin or pitocin ongoing. Okay, then you stop it. When you stop the pitocin, you have to change the client's position. You administer your oxygen. You have to assess the vital signs. You have to also give your IV fluids, or you assist with amnio infusion, where a uterine installation of warm saline to decrease the compression on the umbilical cord if prescribed. However, you have to, first of all, stopping the oxytocin, you have to also elevate the presenting part of the cord. So you have to look, is the presenting path on the cord? So what happens is that you have the cord coming between the presenting path and then the cervix. Okay. So what you need to do is that you have to say you wear a sterile glove, and then you will elevate the presenting part from the cord. Never try to push the cord back. Okay. Never try to push the cord back if you note that there is what we call cord compression, or you see the cord coming out, never try to push the cord back. Yes, Madam Sandra, your hand is up.
Hi, can you please repeat that point for me where you said elevate something? I didn't get it. I think you said elevate the presenting part of the baby's head or something.
Okay,
Sorry.
so what I was saying is that with cord compression, you have the cord coming in between the presenting parts and that of the cervix, okay, and so you can visibly see the cord when you do your assessment, and mostly you have the head being pressed on the cord, and that is what is leading to the restriction with blood flow or restriction with flow of fluid or whatever through the cord. So in order to prevent the cord compression or to elevate the pressure from the cord, what you do is that you wear a sterile glove, then you lift the head, okay? You lift the head or the presenting parts from the cord, and it says that you don't try to push the cord back because you think the head is pressing on the cord. You would want to push the cord back. You don't do that. You rather wear a sterile glove and you elevate the head from the cord so that you can re-establish blood flow through the cord. Yes. You don't give any drug. Someone is asking, what drug do you give for variable D cell? Do you give any drug? If the patient is on oxytocin, you stop the oxytocin, okay, to prevent contraction, further contraction from happening. Okay. But IV fluid is what, so the positions, it was also asking our position. Okay, so I think the preferred position when there is cord compression is that position that will elevate or that will push the head back, or that will elevate the presenting part from the cord. And mostly I think it's the lumbic, okay, where you kind of elevate the lower extremities, and it will also push the head back in, and it will also help lift or push the head off the cord. So that is the position for variable D cell when you have head compression. Okay. But for medication, is there any specific medication to treat cord compression? I stand to be corrected. Our midwives who are with us here, or the one who asked the question, probably you might have come across it and you want to bring it up as well. Other than that, I haven't come across a medication to specifically treat cord compression. Because at the end of the day, they have to even send the woman in for cesarean section to be done. So these are the fetal heart rate tracings, okay? So let's look at them together. This is an LED cell. We said that LED cell happens when you have head compression, okay? Head compression means that the head is coming and it's normal. And we said that the drop in the fetal heart rate will always remain above 100 beats per minute. So this is 100 beats per minute. This is maternal contraction. This is the readings for the fetal heart rate. So you see that this is our 100 beat. Even though we are having some drop in the fetal heart rate, there is a drop here, there is a drop here, there is a drop here. This tracing is not quite good, but I'll try to use it to explain for you to understand, so that when you come across these things in your questions, you'll be able to answer it very well. Now, this is what we call fetal LED cell, okay? And what makes it LED cell is that we said that LED cell has a uniform appearance and it happens together with maternal contraction. So let's look at this first part here. You see here, maternal contraction, this is maternal contraction. It's increasing here, or contraction is happening here. So this is contraction. Contraction peaks here and it starts to drop here. So this is the end of contraction. This is the beginning of contraction, and this is the end of contraction. And this is also the drop in the fetal heart rate. So this is a drop in the fetal heart rate. You see that the drop in the fetal heart rate and that of the maternal contraction is happening together. Okay, the drop in the fetal heart rate is happening together with maternal contractions, or at the time contractions is occurring, that is when you have the fetal heart rate dropping. And the fetal heart rate returns back to the baseline at the end of contraction. So you see that contraction ends here, and then the fetal heart rate has come back to the baseline over here. Okay, so that is what early deceleration is. And I said that early deceleration tells you that the fetal heart rate or the fetal head is descending or is being engaged with the maternal pelvis. Now, we can also take this also as an example here. So this is also another drop in the fetal heart rate occurring here. Then we have contraction also happening here. So at a point when contraction is, let's call it, at a point when contraction is occurring, we have fetal heart rate dropping. However, the fetal heart rate will always stay above 100 beats per minute. Okay, so this is what an early decel is about. And we said our interventions for early decel is I keep monitoring. No need to worry yourself a lot. Okay, it is a reassuring fetal heart rate pattern. Now let's look at variable decel. So I said that variable decel is when you have cord compression. So this is erratic in nature, and it can be non-periodic in nature, has no correlation with maternal contraction. However, this my picture might deceive you that it is happening with maternal contraction. No, if you get a proper a proper strip, you get to understand that you have the drop in the fetal heart rate occurring multiple times during the monitoring. And another thing here that will also help you to know that this is a variable decel is the kind of drop happening. So you look at the drop here, you see that it is close to 60 beats per minute. Okay, you see that the fetal heart rate has dropped to as low as 60 beats per minute. Okay, and for a variable decel, it will have no correlation with maternal contraction. Okay, so you have the drop occurring multiple times, even during in between contractions. If you are to get a very long strip, you will see this very well, where you have a number of the drop in the fetal heart rate occurring in between contraction. So, and like I said, the drop is also very low. It happened as low as 60 or 70 beats per minute, and it can stay there for about 30 or 60 seconds, okay, before it returns back to the baseline. And we said that this is when you have cord compression, telling you that something is being pressed on the cord, restricting flow through it. Then we have late decel. So late decel, when you look at late decel, this is maternal contraction. Then the problem has to do with the fetal heart rate. So the fetal heart rate, there's a drop here. So you see this is periodic in nature, and I'll show you why it is periodic. So when you take this maternal contraction and you take this drop in the fetal heart rate, the drop in the fetal heart rate begins at the point when maternal contraction has also probably come to an end. So at the point when contractions has ended, that is when you have what we call the drop in the fetal heart rate. So this is the first maternal contraction peaking here and dropping somewhere here. Then you have the drop in the fetal heart rate also occurring here. Then, so you have this happening here. So the drop in the fetal heart rate happens at the point when maternal contraction has peaked and ended. That is when you have the drop. Another one also happening here. This is maternal contraction peaking and ending somewhere here. Then you have a drop in the fetal heart rate also happening. And you have a drop in the fetal heart rate. Then you have another one here, another one occurring here. So this is periodic in nature, and it has a uniform appearance with in related with the maternal contractions. So fetal heart rate drops at the point when contractions has peaked and then returned back, or after contraction has ended, that is when you have the fetal heart rate also dropping. Then another thing you can also consider to differentiate it with what we call variable decel is the drop in terms of how huge the drop is. When you compare this, at least this one is a bit better when you compare it with what we call variable decel. This stays a little around 100 beats per minute or around 90 beats per minute, but it will not go as low as 60 or 70 beats per minute. Okay, so this is also how we can also differentiate or understand the various fetal heart rate patterns, so that when we see them, so here this is also abnormal, it is non-reassuring. It tells you that there is uteroplacental insufficiency and then something is happening. You need to inform the healthcare provider, you need to give your IV fluid, you need to give your oxygens and all that. Then we have acceleration. I think I talked about acceleration where I said there is increase in the fetal heart rates during maternal contraction. So this also happens during maternal contraction. And you see that this is maternal contraction. Up here is maternal contraction. Like I showed, this is contraction. This is an increase in the fetal heart rate above baseline. This is maternal contraction, an increase in fetal heart rate. This is maternal contraction, an increase in the fetal heart rate. And we say that this should happen for about 15 seconds, and the increment should be about at least 15 beats per minute, and it should last for 15 seconds. So this also tells you that it is a reassuring indication that the fetus is doing well whilst there's contraction. So you don't need to worry yourself. You keep monitoring. You don't expect the fetal heart rate to stay the same during maternal contraction. At least there should be some increment in the fetal heart rate during contraction, and that is an acceleration, which is good, no problem. Then we have absent variability. Absent variability is bad. It's bad, okay. But we only said that absent variability can happen when the fetus is asleep, and that should last for about 30 minutes. After 30 minutes, at least the fetus should be up and there should be some form of variability or a change in the fetal heart rate. If you have the fetal heart rate staying the same for a very long time, it is a bad indication, and quickly the healthcare provider would need to be informed. Then we have marked variability, where you have an erratic kind of change in the fetal heart rate, and it could either be good or bad depending on the situation. If there is any form of fetal heart rate, if the monitor is giving you this, it could indicate that there is some form of fetal activity. That is why you are having the marked variability. Or it could also be that the fetus is also struggling. That is why, so you will need to probably inform the healthcare provider for further monitoring on it. Then we have a moderate variability, which is good. So if you see this on your monitor, you don't need to worry. You keep monitoring the baby or the mother, and you are good to go. Your non-reassuring ones are the bradycardia, the tachycardia. You have your late decel, prolonged decels, hypertonic uterine activity, decrease or absent viability, then a variable decel which falls less than 70 beats per minute, lasting longer than 60 seconds. These are abnormal or non-reassuring fetal heart rate patterns that if you are able to pick any of these things whilst monitoring your patient, you will need to inform the healthcare provider as quickly as possible, and further interventions will need to be done. So I put this together so that it will serve as some form of a short way to remember what I've just talked about, a lot of things I've said. So we have variable decel. So we have the V chop, okay. The view are the problem, and the chop talks about the causes. So the V is variable decel, which means that there is cord compression, or cord compression is what causes variable decel. early decel, which is the E, is caused by head compression. Okay, no problem. Or head compression is fine, no problem. Then we have acceleration. So acceleration is okay, no problem, no intervention. Then we have late decel, which is also caused by placenta insufficiency. So this is the simple way to remember the various fetal heart rate patterns, at least the common ones that you come across it most time whilst doing your questions, and which ones are good, which ones are bad, and what you need to do. So this is your intervention. We use the lion pit approach. The lion pit approach is that when you notice any non-reassuring fetal heart rate, your interventions are that you lay the mother on the left side, you increase IV fluids, you give your oxygen, you notify the healthcare provider. And so we have pitocin. If you have pitocin on, you discontinue pitocin. So lion pit is lay mother on left or left lateral position, increase IV fluids, oxygen, notify the healthcare provider, discontinue oxytocin or pitocin. But if you are to do, the first thing you need to do, if there is a pitocin on, or if you see in a question that there is any form of abnormal fetal heart rate, and you are to use this approach or this intervention, and they said that patient was receiving oxytocin, the first thing you do is to stop the oxytocin before you lay the woman on the left side. Okay. If there is no oxytocin, you go for the left lateral position before you can do your other stuffs. Okay. Then we have, I think this also gives you the various patterns. Okay, this is not quite clear, but I've talked about this in all, the various part. Yes, Madam Sandra. Hello, Madam
Hi,
Sandra.
sorry, what would be the most appropriate nursing intervention for a patient like that? Which one would be the priority? Is it to stop the oxygen, to connect oxygen, or stop the oxytocin?
Stop the oxytocin.
Thank you.
It will be the first thing if there's oxytocin, and it will still be the highest priority. If there is oxytocin on. Okay. Is there any question, any inputs, any addition on what I've said? Okay, people are already answering my question, eh? The next, okay, Madam Jane, your hand is up.
Yes, it's a question.
Okay, go ahead.
The previous slide, I think where they were presenting on the, I think one of the presentation on the
What was
fetal heartbeat.
Okay.
So if you can move back for me.
You have a question there?
Yes.
Okay. Is it here?
Yes, I think this one.
This one, okay.
The absence variability.
Okay, this is it.
It's something happening. I don't see any like heartbeats. Is it
Yes,
flat or there
yes,
is?
it's like flat. Okay. So
It's
if it
flat.
was to be like an adult, we say that asystole, like asystole kind of thing.
Yeah, that's what I
Okay.
was thinking.
But in the fetal heart rate, you will not say asystole. Okay, you say an absent variability. Like I said, it mostly
Okay.
happens when the fetus is asleep, and that should be for
Mhm.
like 30 minutes. If after 30 minutes you are still getting this, then you have to inform the healthcare provider about it.
Okay, so the initial one, you shouldn't be alarmed, but at least you monitor for about 30 minutes.
Yes, because you can have an absent variability when the fetus is asleep. I get it.
Okay. Okay. Or maybe the fetus is dying.
Yes. So it shouldn't extend beyond 30 minutes for this kind of, fetal heart rates to be there.
Okay, all right.
If after 30 minutes you are still getting an absent viability, you report.
Okay, all right. Thank you.
So people are already answering my question, eh? The nurse is monitoring a client in labor. The nurse suspend umbilical cord compression. Okay, this one there, it's quite simple. No issues here. Quite okay. We all understand that a variable decel will happen with cord compression. Let's look at this. The nurse is caring for a client at 39 weeks gestation who is receiving an oxytocin infusion for induction of labor. The nurse notes recurrent late decel on fetal monitor. Which of the following actions should the nurse take? Select or that apply. Administer IV fluids bolus, reposition the client laterally, discontinue oxytocin infusion, prepare the client for amnio infusion, apply abdominal fibrocaustic stimulation.
Thank you, sir.
Yeah, Madam Mary, your hand is something.
Okay. Good evening.
Yeah, good evening, Madam Mary.
Okay, we just said lion pits. So we have to, first of all, stop the oxytocin, which is a cause. Then we will let the woman lie on the lateral side left. Then we increase the IV fluid before we can notify the healthcare provider. So I think 1, 2, 3 is appropriate.
1, 2, 3.
Thank you.
All right,
It's
thank you.
appropriate.
Got it to Madam Mary. She's going for 1, 2, 3. Okay. And a lot of people in the comment chat is also chat box. I'll going for 1, 2, 3. All right, that's fine. So we have the rationale on the screen. And so applying the lion pit approach, you can get your interventions without any problem. Okay. The nurse is performing telephone triage with a client at 38 weeks gestation who may be in labor. So the following questions would help the nurse determine whether the client is in labor. Select or not apply. 1, do you feel like the contractions are getting stronger? 2, does anything you do make the pain better? 3, have you lost your mucus plug? 4, how frequent are the contractions? 5, where do you feel the contraction pain most?
One, three.
Hey, okay, let me check to see what people are putting there. 1, 2, 4, 5. 1, 2, 3, 4, 5. Okay. Who is ready to talk for us? Yeah, Madam Mary.
Thank you very much. First of all, before labor will start, we tell the people that they will experience the blood mucoid coming out of their vulva. So I think that's a first positive sign to show that there's labor trying to start. Then do you feel like the contractions are getting stronger? Because if it is labor, they can be forced contraction, but if it's labor, the contractions it will be more regular than that of the forced contractions. Does anything you do make the pain better? If it is a labor, I don't think there's something that you can do that will make the pain better. So the pain, you cannot determine when the pain should stop. Have you lost, so I've spoken about the number 3 already. Have you lost your mucus plug? That's the first sign. How frequent are your contractions? So that this one will tell you whether it will give you a clue of how far the contractions have taken, or the client has started having started having labor, being in labor. Either she's in second stage or she's still in the first stage. Where do you feel the contractions pain most? Because with forced contraction, the contractions may not be occurring all over, but at some particular point. So all those things will give a clue of whether to ascertain whether it's labor or it's not. So I'm going for all. Thank you.
You're going for all.
Yes.
Okay. All right. That's okay. Okay. So it is 1, 2, 4, 5. The third option is not there. It's not parts there. As to whether I think that has to do with the mucus plug. Okay. You can have other things that can cause the plug to the woman to show before, but it's not necessarily a sign of labor. Okay. Yes, Kabiru.
Yes, what are the difference between this mucus plug talk about that show? Are they the same thing or they different things?
I didn't get you well.
I'm asking the difference between this mucus plug that is explained here and then that of shape. Are they talking about the same thing or different things?
Yeah, it's the same thing, but it doesn't I mean, there are other things that can cause the show or the mucus plug to break for labor setting. So that is not a true indication that this. Even most of the time you will have the show coming alongside labor, but that alone isn't enough for you to say that it's an indication for labor. Okay.
Okay,
Is
thank
it
you.
that question? Any other input here? Before I'll drop it here for today, and tomorrow, God willing, we'll continue from there. Hey, come up with your questions and other things if you have any, okay, so that we can drop it. We can address all issues before we drop the class here. If there's none, then it's the fetal heart rate. You have to, during and after contraction, you note any form of abnormality with that. Of course, if you already learned the various abnormal or the various fetal heart rate patterns we have, and we know the baseline that at least the normal fetal heart rate is between 110 to 160. So if you have anything outside this range, it means that you have to look at the situation at hand and decide as to whether you would have the report or not. So that is what happens in this. We have you monitor the uterine contraction by either palpation using your tocodynometer or to determine the frequency and duration. You have to provide some form of encouragement. At least our midwives are here, they know what goes on. Some form of praises to help the woman with to provide rest, and you provide rest in between contractions as well. You keep the partner. Privacy is important. Ice chips, ointment for that, dry mouth. Then you assist the client into a position that promotes comfort, at least sidelining. And if the woman is about to deliver, at least either lithotomy, semi-sitting, kneeling, or sidelining, depending on the situation at hand, all these positions can be used in delivering the baby and then providing comfort to the mother. Then you have to also monitor for the baby coming or sign of approaching birth. And here you see the perineal bulging, visualization of the fetal head. Then you deliver the baby, sorry. So you prepare for childbirth, that is portion of the fetus. And that after delivering the baby, you move into the third stage. So when you deliver the baby, there is this thing that you need to do, at least after delivering the baby. You have to suction the mouth. So in sanctioning the mouth, we have between the mouth and the nose, okay, which one do you suction first? Question to the house. Between the mouth and the nose, which of them do you suction first? If you know, you can unmute yourself
The
and
mouth.
you suction the mouth first. So it's just like how if you can't remember this, if you are counting or if you are reading the alphabets, we move from M before you go to N. Okay, so that is one way you can also use to remember this, that between the mouth and the nose, which one do you suction first after delivery of the baby? So we move from M before we go to N. So that is just funny way to remember this, that after delivering the baby, at least you use your bulb syringe to suction the nostrils and that of the mouth. But how do you do it? You do it by starting from the mouth before you go into the nose. Okay, so just for you to also understand this. Then we go into the third stage, a very important stage where you need to deliver what we call the placenta. And in delivery of the placenta, or in delivery of the placenta, after you deliver the placenta, there is an important action that you need to take, that is assessing the placenta to know that all the various part of the placenta is intact, especially the blood vessels. Okay, and I think when I get there, who is writing on my screen? Okay, when I get there, I think I have an image like that. If we want to assess the blood vessels, at least you need to know the number of arteries and the number of veins on the placenta, so that when after delivery you do your assessment and you realize that one of the vessels, especially the one that is two, one is not there, then you need to report that to the healthcare provider. So let's go into what happens in the stage 3. So in stage 3, we have contractions will still occur until the placenta is expelled. So at this point, placenta separation and expulsion will occur. The expulsion mostly occurs within 5 to 30 minutes after the birth of the baby. At this point, you have to assess the center of the placenta or how the placenta will separate. Okay, so we have the scissors mechanism where we have the center portion of the placenta separating first, and that part will have a shiny, fetal surface emerging from the vagina. Then we have the Duncan mechanism where we have the margin of the placenta separating, and that part is also dull in nature, with a bit rough. Maternal surface emerges from the vagina. So depending on which mechanism, that part is not really of an interest. So the method of placenta presentation is no significant interest just for us, or it has no clinical significance. Which part comes first or which part comes later, that is not of an interest, but just for us to understand. The interventions during the stage 3 in the delivery of the placenta is very, very important. Remember, we don't pull on the placenta to try to pull on the placenta to deliver it. That is why you have to allow contractions to occur for the placenta to be delivered normally. If you pull on the placenta, you are likely going to cause the placenta or some fragment of it to tear and then get remaining there. And when it gets stuck, you know that it can cause postpartum bleeding or postpartum hemorrhage. So that is why you don't have to pull on the placenta, just allow the placenta to be delivered or to come out normally. So you have to assess vital signs, very important. You have to also assess uterine status. You provide the parents with some form of explanation regarding the placenta. And then after the expulsion of the placenta, your uterus must remain firm. And then it also has to be located 2 fingers breadth below the umbilicus. The reason here is that if the uterus remain bulgy, okay, it can lead to what we call bleeding. And so when we get into the postpartum issues, we get to understand that after delivery, your placenta must remain firm and it has to be in midline position, at least 2 finger breadth below the umbilicus. If you have the uterus becoming bulgy, shifted to the side, this can contribute to what we call postpartum hemorrhage. So you need to assess all these things to know that you have it. Then the next thing is you assessing the placenta, like I said, the various part of the placenta to know that it is intact, especially your vessel, your blood vessel. So we say that we have 3 blood vessels in there. We have your, so that one's if you want to remember, you use ever. So ever means that you have or ever 2 arteries and a vein. Okay, AVA. If you want to remember that you have 2 arteries and a vein. The ever A is there, then V will be in between the other A. And that means that you have 2 arteries and a vein, just for you to remember. So when you are doing your assessment, they can ask how many. I think there are a lot of questions on that as well. For those who have been practicing more questions on it, you get to know that they will ask you after delivery of the placenta, how many arteries are you expected to assess for? And if you don't know this, maybe you find yourself. So we have 2 arteries and a vein. So you need to assess this and make sure they are all intact, and other part of the placenta should all be intact. You have to assess for shivering, provide warmthness, then or you provide something to cover the mother to control what we call shivering. You promote maternal and neonatal attachment. Breastfeeding is very, very important at this point. Okay, that is when you have to initiate your breastfeeding. Or yeah. Then the last stage we'll talk about is a stage 4, which has the immediate 4 hours. Okay, the immediate 4 hours post delivery. So when you deliver the placenta or the baby, the next 4 hours after that is your 4th stage. And that stage is very, very, very important. That stage is when you'll be able to pick as to whether the woman is having any form of postpartum hemorrhage, even though postpartum hemorrhage can even occur when the woman goes home, when the woman is discharged home. But for postpartum hemorrhage to occur, it mostly occurs within the first 4 hours. Okay. And that is why one of the things you monitor most keenly is about hemorrhage. You have to monitor for hemorrhage in the 4th stage. So this is the period 1 to 4 hours after birth. Over here, that is when you expect blood pressure to return back to the pre-labor level. Pulse might be a little lower than during the labor. The fundus will remain contracted in the midline, and it should be 1 or 2 finger breadths below the umbilicus. You monitor discharge of lochia. So at this point, we'll do lochia, we'll do the various lochia, we'll do rubra, we'll do serosa, then we do alba, and then we'll get to understand them. But at this point, you have to monitor for the lochia. And I think the first lochia that will come is serosa, right? Serosa, right? So or rubra, which one comes first?
Right.
Rubra, okay. So rubra before serosa, very good. So you have to monitor because rubra will occur, I think, within the first 7 days. That is when you expect rubra to occur. So you have to monitor for rubra at this point, you have to look out for the amounts. Okay, so local may be moderate in amounts and then red in color in the fourth stage, and that is how the rubra looks like. I mean, local rubra is red in nature. Then you monitor the amount. The amount is very, very important. The amount of blood loss. Okay. Remember, they are not really going to tell you, but one thing that will tell you that the woman is bleeding is how the consistency at which the woman changes the pad. Okay. So it says that if you are monitoring a woman in a postpartum period, especially within the first 4 hours, and the woman tells you that she's changing her pad multiple times within an hour, okay, or you change a woman's pad. In a question, they say that a woman pad was changed multiple times in an hour, then that should tell you that the woman is bleeding or the woman is having postpartum hemorrhage. So you need to report that. It shouldn't be completely soaked. Okay, so let's look at your interventions. Here, you have to monitor the woman every 15 minutes within the first 1 hour. We are saying that this period lasts for 4 hours, but in the 4 hours, every hour and what you do, or every hour and how long you should monitor the woman, or the number of times you should monitor the woman. So for the first 1 hour, you do your monitoring every 15 minutes. So that means that within the first 1 hour, you monitor the woman 4 times. Okay, every 15 minutes. Then every 30 minutes for the next 1 hour. So the next 1 hour, you also monitor every 30 minutes. So first 1 hour, 15 minutes, that is 4 times. Then another hour will come, you do monitoring 2 times every 30 minutes. Then the last 2 hours, you do your monitoring 1 hourly. So that means that the last 2 hours, you also do 2 monitoring. But this is the standard of the NCLEX. You know that in the US, every facility and then their agency protocol, the facility protocol you need to follow. But for the purpose of the NCLEX, at least this is how long, or this is the consistency at which you need to monitor the woman within the first 4 hours after the baby has been delivered, and that is in the fourth stage. You have to provide comfort. You apply your ice packs, especially if there is any form of tear or any form of cervical tear, or there was an episiotomy and then there is pain, hematoma or something like that, you need to control the pain. One of the things you can do is applying ice packs over there to relieve the pain and provide comfort. You have to massage the uterus if needed, especially if it is bulging, shifted to the side and the woman is bleeding. You have to massage the uterus. Then you provide, breastfeeding or chest feeding support as needed. So like I said, here you monitor for bleeding. And if you are monitoring for bleeding, you are looking at how many times you are changing the woman's pad. Are you changing the woman's pad multiple times within an hour? If that is occurring, then that could indicate that the woman is really bleeding, especially if the question it says that within the first 15 minutes, the woman's pad was completely or 100% soaked. Sometimes they use percentages. It will say that within the first 15 minutes on assessment, it was noted that the woman's pad was 100% soaked. If it is 100% soaked, it means that you need to replace the pad, and that is an indication that the woman is bleeding. You need to inform the healthcare provider about it for further actions to be taken. So that is the first part of my class for today, and it talked about the stages or the various stages in labor and then delivery. So I will end it here. If you have a question, you have an input you want to make, you can bring it on board before we go through 1 or 2 questions, and then we proceed from there to problems in labor and delivery. All right. Yes, Madam Sandra, your hand is up.
Hi, I just wanted to ask a question.
Mhm.
So, can you give a duration for how long each of the stages of labor should take so that if you know that
The whole stages, or
yeah,
each of
like
the
for
stages.
each of the stage, if the patient is not progressing, then you know that this patient has lasted more time than necessary in this stage of labor. So then you have to act on it.
Okay, so I think for the entire labor duration, I know the entire labor duration should last between 18 hours, okay? For
Okay.
the whole stages, okay? It should last for about 18 hours. But then let me confirm for that of the various stages, okay? But if someone has the person can bring it on board, okay? Yes. But for the entire labor stage, it should last for about 18 hours. Yeah.
Thank you.
All right. So whilst we wait for that, let's do these questions on our screen. Is there a question for me on the chat box? I made mention of that. Placenta delivery is mostly within 5 to 30 minutes. Okay. So someone is asking, Mother Raquel, what's the maximum period within which the placenta must be delivered? I think I made mention of that. Okay. That placenta delivery should occur within 5 to 30 minutes. So after 30 minutes, the placenta is not delivered. You might need to report that as well. All right. A neighboring client reports feeling the need to have a bowel movement. It says that bowel movement and begins vomiting. The nurse notes that the client's legs are trembling. The cervical examination findings. What cervical examination findings would the nurse expect this client to have? One is 2 cm dilated, 50% effaced, -2 station. 2, 6 cm dilated, 70% effaced, -1 station. 3, 70 cm dilated, 7 cm dilated, 80% effaced, 0 station. 4, 8 cm dilated, 100% effaced, then 1 +1 station. Okay. Okay. So I think we have people providing, yeah. And it says in the comment chat or comment section, yeah. Hey, say my screen sharing is paused. Can you still see my screen?
Yeah, I can see.
Yes,
Okay.
please.
Okay. So we have 4. Okay, someone says no, I can't see your screen. Okay. I'm getting a feedback here that my screen sharing has paused. Let me see. Is it? Okay, let me. Okay. I think. Let me see this. Okay, it has resumed. All right. So yes, the fourth one is the answer, as we can see it there. Okay, and that is what tells you that the labor is progressing. Okay, if you look at the various assessments that was provided. The nurse is caring for a client in labor, which assessment findings indicates to the nurse that the client is beginning the second stage of labor. Sata, the contractions are regular. The membranes have ruptured. The cervix is dilated completely. 4, the client begins to expel clear vaginal fluid. 5, Ferguson reflex is initiated from perineal pressure. This is SATA. So let's answer this SATA question. All right, let me see. Someone's going for 3-5. Come up with your reason why you're going for that. Okay. Hey, no one is talking. Someone should also talk. Tell us why she's going for that. Okay.
Hello.
Yeah, hello.
Please, me, I'll go for
You go for only
3.
3. Okay. You are playing a safe game, eh? Okay.
From
Okay.
the presentation, you made mention that the first stage ends at where the cervix is fully dilated, and the
Mhm.
second stage is from the I was just
Okay. So you are sticking within the. She's going for the third one. She doesn't want to add up anything to get a negative mark. Okay. Okay. Others are going for 1-3, 1-3. Some people are going for 3-5. Okay. Those going for 1-3. Why 1-3? So we have 3-5. Okay.
Hello.
Yes, hello.
Please, I wanted to ask a question about
Mhm.
the selector that applies. Anytime they ask a selector that apply, is there a clue as in you wouldn't have to choose only one answer? Definitely
Hmm.
there will be one, more than one answer.
No, so the answer can be one. Okay, the answer can be only one. And the answer can also be all the options or like some of the options. At first, okay, at first, SATA cannot be all, and then it cannot also be one. But in recent times, okay, those of you who have been doing you would like that. There are some questions in you that all the options are correct, and you have to select all. So the idea now is that at least for SATs, you can get only one to be the correct answer, or you can get all the options to be correct, or you can get some of the options to be correct. So it depends on how you analyze your question and the options. Okay. So it is not a one-way thing. I get me, madam.
Yes, please. Thank you.
All right. All right. So someone was asking if I could go back to the question. Hey, the question stayed there for more than 5 minutes. So see, the reason why they are not adding the one to it is that the one is not peculiar to what is it? the stage 2. Of course, contraction would need to be, regular, okay? But then we want things that are like specific to only that stage. That is what the question was asking us for. The question was demanding for things that is specific to only that stage. The contractions being regular will be for all the various stages. Okay, you have contraction being regular for all the stages, but we're looking for things that are specific to only the stage 2. That is what the question was demanded. That's why the one wasn't part of the options provided. All right. The nurse in the labor room is caring for a client in the active stage of the first phase of labor. The nurse is assessing the fetal pattern and notes a lady cell on the monitor strip. What is the most appropriate nursing action here? We have administer oxygen via face masks. You have to place the client in a supine position. You increase the rate of oxytocin infusion. You document the findings and continue to monitor. For this one, no one will go for the option 4. If you go for the option 4, it means that will give you canes. So I believe no one is going for the option 4. The moment you spot this, you can't say you continue to monitor. You can't also continue your oxytocin or increase the dose. And so oxygen is likely the appropriate intervention for you to do, as we're answering in the comment section. I'll do one more question and then I'll move to what I have to do next for this. I have quite a number of questions, but since we want to cover much, we will need to also make progress. Yes, Madam Sandra, your hand is up. Yeah, hello, Madam Sandra. Kindly unmute yourself and then.
Hi, sorry. I have a question. Okay. So if you notice early deceleration like this, and then you have options like to administer oxygen to the baby, to the mother, and they put the mother on the sideline to the left.
Yes.
Which one is the most priority to take, assuming you've been given both answers in the question? Which one will be the most appropriate thing to do?
So the question, this is
no, that one is not part of it, but
yes.
I'm assuming that
yes, you are assuming that you have between oxygen and then
left
okay,
lateral.
so if it's about what you do first, okay, let me say, if it's about what you do first, will be the position, but your priority here will be the oxygen at this point.
So is there a difference between what you do first and priority?
Of course, there are. So the priority intervention is like one thing you can do for this woman, and then like if you do that thing alone, okay, that alone can solve a chunk of the woman's problem.
Okay.
Or like one thing you can do to save someone in terms of the highest priority between the position and then the oxygen. Okay. If you have to choose which of them you will do, and then it will benefit the woman most. That is when you are asked on priority. But it comes to first thing, like what you do first. However, you can have something to be the first thing you do and to still be the highest priority.
Okay.
Okay, so the English is quite dynamic. The more you answer questions, you get to understand some of the tricks and that.
Sometimes they put it as what is the best action?
Best action, exactly. Yeah, what's the best action? Okay, and you can have what's the best action and what's the first thing you do. So the first action could be the same as the best action you do for the person, but you can have instances where you have the first thing there. I'm trying to get a question where, or something that we can relate that, but it's not coming. But you get a lot of questions like that. Okay, what you do first and what's the highest priority? Like I said, the highest priority or the best action is like one thing that if you do, that can save the person. And the first could be that when you do the thing first, that will not be the ultimate goal. At least you need to do additional things again. in order to help save the person.
Okay, thank you.
The nurse is performing an assessment of a client who is scheduled for a cesarean delivery at 39 weeks of gestation, which assessment findings indicates the need to contact the primary healthcare provider. We have a hemoglobin of 11 grams per deciliter, fetal heart rate of 180 beat per minute. Then we have maternal pulse rate of 85 beat per minute, and a WBC count of 12,000. This is also quite easy, simple for us to come up with it. Of course, when you look at all the other options, apart from the second one, which is quite alarming, the other ones are not something that you really worry yourself about. Okay, so that will be it for the first part of my class. We're going, so this is the rationale for those ones. The rationale is the second one, and of course the 180 is out of the normal range, so you need to do something else. Okay, let's move from there and then go into the problems of labor and then birth. So we'll be looking at premature rupture. We'll be looking at preterm. I think preterm is part and the various things. Okay, so let's go straight into it. So here problems, we are first talking about premature rupture of the membranes, and over here, like the name goes, the membranes will have to rupture, or the membranes ruptures spontaneously before the onset of labor. And when this happens, one thing you need to consider is the gestational age of the woman. You need to consider the gestational age, and that is what will guide the healthcare provider with a plan as to whether the healthcare provider will go ahead to deliver the baby or will give some form of, medication to kind of, sustain the labor up until maybe some few hours, if that can happen. And again, another thing in premature rupture that I want everyone to take note of is infection. Infection is one of the highest, problem, or is one of the major problems that accompanies what we call rupture. So when you are reading a question and it's about premature, they will ask you about infection and all that. So you need to protect the woman from infection, because after rupture, probably maybe you might want to do your vaginal examination and all that, and the likelihood that you're going to transmit infection is very high. So you need to do everything possible to protect the person from infection. And you have to also assess the fluid. Okay, if you notice that the fluid that is coming, it has some bad appearance, okay, the amount, the consistency, the color, if there's any form of odor, it could tell you that there is an infection. And like I said, infection is one of the major things you need to do. So when this happens, like I said, the healthcare provider will need to consider the gestational age before the interventions for it will happen. The rupture, the major problem here is that when the rupture of the membrane is before term and birth will be delayed, infection is the major problem. Okay, so the healthcare provider will now have to weigh the pros and cons, whether to go ahead with the delivery or will have to delay the delivery. And when they are delaying it, the major concern here is infection. When there is a rupture of the membrane, how do you, yes, Madam Ayako. Yeah, your hand is up, Madam Ayako. Kindly unmute yourself and then come in. Whilst we wait for Madam Ayako, we will continue when she comes on board. Then we'll listen to her question or her input. So, you have to, of course, test the fluid to know that it's actually the membrane that has ruptured, or it's actually the amniotic fluid. And so when you are coming to test the amniotic fluid, we use the nitrogen test. And the nitrogen test, it's just like when we were in school, we are testing for acid and then bases. Okay. We know that the pH of this vaginal fluid, okay, should I say that it is acidic in nature? Okay. But then for the amniotic fluid, it is, the pH is around, I think 6 point, let me confirm. But when you test, okay, what you do is that we use like a litmus paper to test this, or a nitrogen paper. And the nitrogen paper, if it is actually an amniotic fluid, what will happen is that the color of the paper will change to blue color, or it will change to blue. Okay, so any other color change indicates that it is not amniotic fluid. However, you can get a false positive result, and a false positive result means that there are other factors that can contribute to the change in the color of the litmus or the nitrogen paper. And one of the things is when there is semen. So we say that when there is a rupture of the membrane, one thing you need to question the woman about it is that, as to where, or when the woman presents to you that they've had she's experiencing maybe fluid coming out, and you think it's a ruptured membrane, one thing you ask the person is whether the person has had sex. And if the person has had sex, then if your results was positive, then you should be thinking about it again. So asking about sex when someone presents with a ruptured membrane is very, very important, because semen can give you a false positive result. And when there's a false positive result, you might need to do further assessment about it. So asking about sex just when the woman presents is very, very important to rule out any kind of false negative or false positive results. Okay. And I think some form of, chemicals, if the woman douche or something like that, can also alter the result of a nitrogen test. Then you have to look for the amount, like I was saying, how much of the fluid is coming, the color, the odor, the odor is very, very important, because if there is an infection, the woman is going to present with a foul odor. So you have to look for the odor, you have to assess the odor of the fluid. It shouldn't have any abnormal, smell. If it is presenting with a smell, abnormal smell, it could be infection. Then if there is also infection, you know that maternal temperature is going to go up. And when maternal temperature also is high, you also have the baby also having the fetal heart rate mostly also goes up. So whenever you are checking the fetal heart rate and the fetal heart rate is up, sometimes you need to also assess the woman for infection as well. So you have to monitor. Fetal monitoring is high. So tachycardia in the fetus may indicate maternal infection, like I was saying. Your interventions here is that you have to assess the gestational age of the woman. And if the woman is in a term gestation, 37 upwards, probably labor will continue, on the healthcare provider will allow labor to set. But then if it is less than 37, of course, the healthcare provider would also have to assess to see, is it closer to term gestation? If it is closer to term gestation, labor might be allowed to continue. But if it's around, let's say 30, 32, where there is preterm labor, maybe the healthcare provider would need to give other, medication to delay the labor, because of certain complications that accompanies what we call preterm labor. So you have to avoid vaginal examination because of the infection. When you notice that, or when you have a suspected ruptured membrane, you don't have to do vaginal examination because of infection. Then you have to monitor the maternal fetus for signs of infection, and then signs of compromise, if there's any. Then antibiotics will be very, very, very of high importance here, because if there is an infection, it is antibiotics that you need to do. Sometimes, even in the mature ruptured, in the initial stages, the antibiotics will be administered as a form of, prophylactic or for prophylactic measures to prevent infection. So that is on premature rupture or premature rupture of the membrane. And some of the things you need to, at least we need to understand and do for the woman, and how we also have to assess. So I said that infection is the highest thing you monitor when there is ruptured membrane or when there is premature rupture. The next thing we do after the membrane has ruptured, okay, what happens is that the membrane, when it's ruptured, of course, it's fluid that will come out. So it's the amniotic fluid that will come out. So when the amniotic fluid is coming out, one thing that it mostly does, or one thing that happened alongside the fluid coming, is that the fluid can sweep the cord. So when the fluid sweeps the cord alongside, then you have the cord coming between the presenting parts and that of the maternal cervix, or between the cervix and that of the presenting part. And that is what mostly causes what we call prolapse cord. So prolapse cord is when you have the umbilical cord being displaced between the presenting parts, and then the amnion or protruding through the cervix, causing compression of the cord and then compromising fetal circulation. And like I said, one of the major things that causes prolapse cord is when you have a ruptured membrane. The ruptured membrane, the fluid inside it sweeps the cord alongside. And when it sweeps the cord alongside, the likelihood that the cord will come in between the presenting path and that of the maternal cervix is very high. And this can lead to prolapse cord. And remember, we said that cord compression will lead to what? Variable deceleration. So you need to monitor for this as well. So on your assessment, if you have prolapse cord, you're going to have the client has a feeling that something is coming through the vagina, because it's like it's a cord that is coming. So the woman will have such a feeling. Then you have the cord, you can visibly see it, or you can palpate it as well. The fetal heart rate is going to be irregular and slow, like what happens in variable decel. And so you know that in variable decel, the fetal heart rate is going to go down, and then it also become irregular as well. So the fetal monitor will show a variable decel or a bradycardia after rupture of the membrane. So that is what I'll say, that when the membrane ruptures, it mostly pulls the cord alongside, and that is what mostly leads to umbilical cord prolapse. Then there's going to be fetal hypoxia due to the impairment in the flow of blood or flow through the cord. So that will lead to fetal hypoxia. And when there is fetal hypoxia, the fetal activity at least is going to increase. Just like if someone is struggling to catch up oxygen, you know what happens? The person becomes more aggressive. And then later on, if the person does not get help or support, the person will go off. And so the same thing applies to the fetus. If there is compromised circulation and the fetus is having fetal hypoxia, in the initial stages, fetal activities will increase. And as time goes on, at least there will be a cessation of the fetal activity. And as long as the fetus is probably going to go off or die. So you need to, that is why I said that, to me, variable decel is one of them. In terms of which one is worse, at least the variable decel is quite worse, and you need to intervene as quickly as possible. So when this happens, one thing you do is that the goal is to relieve the cord pressure. So if you want to relieve the cord pressure, one thing you do is that you have to, yesterday I said that you elevate the presenting part of the cord. So you do not attempt to push the cord into the uterus. Then this situation is an emergency, so delivery will have to occur. Via a cesarean section. You have to elevate the presenting part that is lying on the cord by applying what we call finger pressure with a sterile glove. So it says that you wear a sterile glove and then you have to elevate the presenting parts of the cord. Then you place the client in the Trendelenburg position or modify lateral position or knee chest position. One thing is that you're not going to get all these positions in one question. At least they will have to bring one. Okay. Either you get a knee chest position or you get a Trendelenburg position. Most of the time, these two positions they do bring along. Trendelenburg or knee chest position. Then the woman will be transferred into the theater for care. Then another thing you need to also do is that in order to prevent the cord from cracking or due to exposure to air, you have to cover the cord with a soaked sterile gauze in normal saline. So you have to get a sterile gauze, then you soak it in a normal saline, then you wrap it around the cord loosely. This is to prevent the cord from drying up and cracking. When it cracks, likelihood that infection or bacteria will find its way through the cord is high and leading to infection. So you need to make sure that you wrap the umbilical cord loosely in a sterile towel saturated with warm saline or warm sterile normal saline. You monitor the fetal heart rate, you assess for hypoxia. You prepare to start infusion, of course. We said that in variable this you have to increase the amount of IV fluids you are giving, normal saline or Ringer's lactate. And then you have to stay with the client. Never leave a client who is having a prolapse cord. Okay, never leave the client alone. Ask your assistant or whoever is with you to inform the healthcare provider, or if you need something, someone else will need to get it for you. Then you have to call for assistance. I've said that oxygen will be important. Remember, we talked about lion pits. So oxygen is here. I've talked about wrapping the cord, document your action. All this thing, if there is oxytocin on, you need to stop the oxytocin as quickly as possible. So that is on prolapse cord, and then the intervention for prolapse cord as well. If you have a question, you have an input you want to make, you can bring it on board. The one whose hand was up, the person could not ask the question. Okay, I'm still waiting for you. If you still have a question, you can bring it up board. The next thing we talk about is supine hypotension. I think this is not any big deal I would want to spend much on, but in supine hypotension, we are looking at client position. The major thing is that we don't position pregnant women in a supine position. Okay. And when you position the person in a supine position, what happens is that the pressure from the uterus will be exerted on the vena cava, and that would affect what we call cardiac output. Okay. And when cardiac output is affected, you're going to have hypotension. The client is going to experience what we call supine hypotension. Okay. When the client changes position from the supine to, let's say, sitting or standing, you have the client having a drop in their blood pressure. And so the client will have dizziness, it's going to be syncope. Then when cardiac output is reduced, pallor will be there. There's going to be tachycardia as a form of a compensatory mechanism to make up for the reduced blood in the system or the reduced pumping ability of the heart. There's going to also be some form of coldness, thumb skin, sweating, fetal distress, because the fetus will now also get adequate oxygenated blood. Your interventions over here is that never position the woman in the supine position. Always assist the woman in a left lateral position or a lateral position based on what you are even doing. But for putting the woman flat on the back, it is a no-go area. So position the client on the side to shift the width of the fetus of the vena cava until the client's symptoms subsides and vitals are also stable. You monitor the vital fetal heart rate. To prevent this, avoid supine position. Position the client by placing a pillow or wedge under the hip to displace the gravid uterus of the vena cava. So that is generally what at least we all need to know when it comes to positioning the woman. In order to prevent this syndrome, you have to avoid supine position. Here is preterm. So in preterm, we are looking at labor setting in or labor occurring after 40 weeks and before 37 weeks. After 20 weeks and before 37 years. So anything, if labor happens within this duration, we call it preterm. And we know that if it is before 20 weeks, it is abortion or miscarriage. Then after 37 weeks, we term it, it's a term gestation. So anything within 20 to 37, it is a preterm. The reason why we are doing this is, at least in the preterm stage, you have to look at the complication that accompanies it, some of the predisposing factors or risk factors that will put a woman at risk of, going into preterm. At least we also need to know that. So if you have labor occurring within this duration or this gestation, week of gestation, it is preterm. Some of the risk factors, they are varied, a lot of risk factors. Most of them, if there is any underlying medical condition, especially cardio conditions, okay, if the woman has any form of cardio-related condition, if the woman has any past history of obstetric problems, okay, it can equally lead to that. Infection is also another contributing factor. Then social environmental problems, if there is any form of abuse, it is also another. Then you also have substance abuse. If the person also tends to abuse drugs, it could also contribute to preterm. You have what we call multi-fetal pregnancy. So if the woman is probably having carry more than 2 fetus, the likelihood that preterm will happen is also high. So multi-fetal pregnancies is also another contributing factor. Then the age of the mother is also another thing. If someone gets pregnant before 18 years, the likelihood that the person is going to have, or the chances of preterm is also there. And then after 40 years. So if someone gets their first, especially if it's their first pregnancy, so age younger than 18 or first pregnancy, and age older than 40. So older than 40 and then less than 18 are some of the risk factors. You could have anemia. You could also have a decreased oxygen, which will decrease oxygen supply and all that. Then generalize like other medical conditions. Like I said, heart-related conditions are all there. You could put the woman at risk of having preterm labor. The assessment, what will tell you that someone is having a preterm labor would be 2 signs of labor. So you have to look out for signs of true labor. So let's say someone at 30 weeks of gestation is presented that the person is having contractions which are regular, and then the contractions are also occurring closer together. Then they tell you that the woman complains that pain is located at the back, okay, or the lower back. We know that true labor sign in terms of the location of the contraction pain, we said that it is at the back, okay, back pain. Then that should come into your mind that this person is likely having what we call a preterm or experiencing preterm labor. So you need to put down your interventions and then inform the healthcare provider on that. So you're going to have contractions which will be mostly painful, regular in nature. The abdominal cramping will also be there. It may be accompanied with diarrhea. Lower back pain, or where the pain is located, is very, very important. So low back pain is there. Pelvic pressure or heaviness is also another thing. Then changes in the character and amount of unusual discharge. So that is where you have blood issue and all that coming in. Then we also have ruptured amniotic membrane. So at this point, that is where premature rupture will also come in. Because premature rupture can also lead to what we call preterm labor. You also see some form of fetal, appearances in the cervical membrane or cervical canal. Then there's going to be shortness of the cervical length as well. When there is preterm labor, the focus is probably to kind of halt the labor or delay the labor if that can be done by the healthcare provider. But if the healthcare provider notices that the labor cannot be halted or cannot be delayed, then of course, delivery will have to continue. So at this point, focus will be on stopping the labor. And to stop the labor, of course, going to give your max sulfate, another thing that will suppress contractions. You have to also give your steroids that will also help with lung maturity. You also give your surfactants that will also help with increasing lung maturity in order to prevent respiratory distress syndrome and all that if the fetus is born. So you have to also look at the gestational week of the woman or the week in which this is happening. That is what will also guide the intervention. So the focus will be on stopping, identify, and then treat infection if infection is there. You restrict activity, you ensure hydration, you have to maintain bed rest, lateral position will also be there. Then you have to monitor the fetal status, you administer your IV fluids, then your medication. You have to administer medication as prescribed. You monitor for side effect of your tocolytics. So your tocolytics, the max of it is there. Nifedipine is also a form of tocolytic that is also used as well. But I think the most common one that we are all aware of is the max sulfate, which will help to halt contraction to prevent labor from progressing. Then we also have what we call 17-alpha hydroprogesterone caproate, which also helps to decrease the risk of what we call labor, preterm, delivery. The next thing we talk about, I think this should be my last 2 or 3 things. I think I still have a lot of things to talk about before we touch on 1 or 2 questions. Okay. The next thing we talk about is precipitous labor and delivery. And we said that at least for normal labor should last for at least from the beginning of labor up until when you deliver the baby, or it should last for about 18 to 19 hours. That is the extent of labor. However, you can have a woman who presents with labor and within 3 hours, the woman is going into labor or the woman is put into bed. And that is what we call precipitous labor. So precipitous labor is when you have labor occurring in less than 3 hours. In less than 3 hours, if a woman presents and then is going into labor within the first 3 hours, it's called precipitous labor. What you need to do is that at this point, you cannot stop the labor, because when you stop the labor, it will come with its own complications. So you need to go ahead and do your delivery, or you need to deliver the baby. You don't need to stop the labor. Go ahead and do your delivery. So in precipitous labor, when you get a question, and the question will be put in such a way that you know that it is actually precipitous, you have to look at the time that the labor is starting and the time that we said the woman is showing sign of probably pushing. Okay. And that will tell you if it's precipitous, and your intervention will also be there. So in precipitous labor, we say that the interventions, of course, the assessment will be that like within 3 hours, the woman is showing sign of putting to birth, or like stage 2 where the woman is pushing, everything is coming and you need to deliver the baby. So at this point, you don't stop the labor, or we don't do anything to halt it. You have to make sure you have for every, maternity ward as a nurse, awaiting a pregnant woman to deliver, at least you have to have your emergency resuscitation tray available, and that is your precipitous delivery tray should be available. It should have a hemostat, a scissors, and a cord clamp with it. Then you stay with the client at all times. You don't have to leave the clients. You have to provide emotional support and all that. You encourage the clients. You prepare for rupturing membrane when the head clouds, and if they are not, you have to, if they are not already ruptured, then you do not try to prevent the fetus from being delivered. That is my take-home message for this. If you forget anything at all, when you have your option, at least they will bring something like try to delay the pregnancy, okay, or try to do something to halt the pregnancy. But if you have precipitous labor, go ahead and then do your delivery. Don't try to halt the labor. Then we go into shoulder dystocia. As we know that dystocia is what? Abnormal, should I say pregnancy, or when you are doing your delivery and there is any abnormality. And one of the common things in the NCLEX you come across is shoulder dystocia. And they will ask you about the intervention for shoulder dystocia. Whenever I'm doing shoulder dystocia, I always go and show what we call McRoberts maneuver, because of experience I've had with some Cubans. So they will kind of bring the interventions, okay, or they will bring the interventions in the form of a picture, and you need to choose which one is showing what we call, McRoberts maneuver, and you have to choose between them. So the McRoberts maneuver is the intervention you use to deliver a baby when there is shoulder dystocia. So this is an obstetrical emergency where you have the fetal head emerging, but you have the anterior shoulder remain wedged behind the maternal symphysis pubis. And when that happens, it means that delivering the baby becomes very difficult. The findings you see is that you see the fetal head retracting back towards the maternal perineum after birth of the head. That is telltale sign. This is mostly, shoulder dystocia is mostly associated with when you have macrosomia or when the baby is big, okay. That is why you have to screen every woman for DM, okay. That is you have to screen the person in the initial stages of pregnancy as to whether the woman is at risk of having any form of DM, or yeah. So because when there is, the woman is a non-DM, the likelihood that the baby or the fetus is going to get a lot of sugar, and that will lead to the buildup or the baby becoming fat, is also high. And so you have to monitor all this thing, because shoulder macrosomia is one of the contributing factor to this. So gestational diabetes is one of the things that will lead to macrosomia. Like I said, when there is excess sugar, the baby will also feed on the mother, and that will lead to the buildup of excess fat and all that. That will lead to the macrosomia. So we have to know that. That is why in most of the time when the fetus is big, okay, or is beyond is above 4 kg or 4,000 grams, or above 8 pounds 13 ounces, they might not really allow the person to go through normal spontaneous delivery, and then probably cesarean birth will have to be done to prevent this kind of complications. When shoulder dystocia happens, okay, so another factors that can also lead to it, when you have suboptimal pelvic shape of the woman, mostly those who have the short stature, okay, people who are short, or short women, we know that most of them will have, a suboptimal pelvic shape. I think we all know that for an optimal pelvic shape, it should be the gynecoid pelvis. But if you have the other pelvis, okay, the likelihood that it's when you are delivering, it's going to give you some challenges is there. So suboptimal pelvic shape is there. Obesity is also there, and obesity itself can also lead to macrosomia, then short stature. Then we also have rather than the fetal size. These are all things that can lead to what we call shoulder dystocia. Interventions for shoulder dystocia is where my interest is. Okay, performing the Macrobert's maneuver. And this is when you do a sharp reflex of the maternal thighs. I'll show you the picture so that we can appreciate it. We have a sharp reflex of the maternal thighs towards the paternal abdomen. What this does is that it helps to widen up the pelvic bone and that of the sacrum so that the shoulder that has gotten wedged behind the maternal symphysis we can easily be rotated back, and then delivery will continue. Then when you do this, you apply some form of suprapubic pressure. That is a downward pressure applied to the maternal pelvic bone to dislodge the shoulder. Let me show you a picture of Macrobert's maneuver so that when you are reading and then you come across this, you would appreciate it when you have an option where you have to choose a picture. Okay, I think I already have. Okay, so let's look at a picture of it. For those who are using U1, I was using U1. That is why I like you referring to U1. Okay, okay, this is it. I have this here. Okay. So this is it, okay, where you flex the maternal thighs towards the abdomen. Then when you do that, you apply pressure at the suprapubic area to dislodge the shoulder that has got wedged behind it. Okay, let me see if we can get another. So this is also another one. I think this is much more clearer. So this is shoulder dystocia. Sorry, interventions for shoulder dystocia, which is Macrobert's maneuver to help deliver the shoulder that has got wedged or to dislodge the shoulder. So when you have, they will give you 4 pictures, okay? And out of the 4 pictures, you have to spot which one truly demonstrates what we call Macrobert's maneuver, okay? All right, so that is what I will show for Macrobert's maneuver. For those of us who are monitoring from the screen, I hope you've seen the interventions for Macrobert's maneuver. And so that is on Macrobert's maneuver and what you do for the woman or intervention you have to put in place for shoulder dystocia. My next thing will be on rupture of the uterus. And when it comes to rupturing of the uterus, of course, we are having the uterine wall getting separated. And we know that.
Amigo,
Yes, madam.
please, please, I have a question. I know that with this shoulder dystocia, there's another method that's used. I don't know whether it's applicable in terms of NCLEX, like the fundal pressure that we give. I don't know if that one is also
Is it only
another
fundal
method.
pressure?
Sorry?
Is it only fundal pressure?
Yes, I know that they give fundal pressure while the other person will also be trying to help the baby come out.
For the purpose of the ankles, okay. If
Yeah.
you want to manage shoulder dystocia, always go for a description that tells you that it is Macrobert's maneuver. So sometimes they describe it, okay.
Okay.
If you have fundal pressure, they're applying fundal pressure, and you have a description for shoulder dystocia, go for shoulder dystocia. Oh, sorry, a description for Macrobert's maneuver, you go for that. Okay.
Okay. Okay. Thank you.
All right. So let's do a ruptured uterus, and then we looked at what's. I think here we will not waste much time. The types are not really of interest. Here we have a tear in the wall of the uterus from stress, and one of the major things that leads to ruptured or rupturing of the uterus or ruptured uterus is one, when you have any form of pressure being exerted on the abdomen, okay, and this can be like an RT when the woman gets RT or when the woman gets involved in an accident, a road traffic accident. The likelihood that, or it can lead to what we call ruptured uterus. There can be some form of pressure exerted on the abdomen, and that can. Another thing is when you have the woman going into cesarean section, and then within less than 2 years, the woman give birth, the woman get pregnant again and want to go through, normal spontaneous vaginal delivery. The thing is that is why in most of the time after if you've had CS and then within 2 years you are pregnant again and going to labor, they might not allow you to undergo normal spontaneous vaginal delivery. Is the risk of rupturing the uterus, because the pressure from the labor, the contractions and all of those pressure could lead to an opening of the uterus, and that can lead to the uterus rupturing. So that is one of the things that leads to it. So we can have complete one, we can have incomplete. So incomplete means that you have the tear of the rupture into the perineum. So you have the stomach covering whenever the rupture happens. You have the stomach lining still covering what we call the content of the uterus. But when you have a complete one, you have the entire content of the uterus in the peritoneal cavity. And so that is the income. Kindly mute out for us, Madam Dahlia. Dahlia, kindly mute out. It's okay. You could have, when there is a ruptured membrane, the major thing you see with the woman is that there's going to be bleeding. So bleeding is the highest thing or the highest issue with these people. So the risk factors, like I said, previous cesarean section, a distended uterus. So if you have like a multifetal pregnancy, that is also another thing. Or then if you have a cesarean section, like I said, abdominal trauma, they are all contributing factors. Your assessment will show that a woman will present with abdominal pain, tenderness. It's going to also be some form of chest pain. The patient's contraction may stop. Of course, the uterus has ruptured, so it is the uterus that would have to contract. So the contraction may stop or may not progress. The abdomen will become rigid on assessment. Fetal heart rate may be absent. Because of the bleeding, the woman is going to go into shock. So bleeding will lead to maternal shock. You'll have to palpate for the uterus, the baby or the fetus outside the uterus, especially when there is complete rupture. Because I said that with the complete rupture, you have the entire content of the uterus in the abdomen. Okay. But for incomplete one, you still have the peritoneum or the abdominal covering still covering up the content, and then the content does not get engaged with the abdomen itself or the peritoneum. So that is it. The interventions are that the shock is that you have to monitor for bleeding, you treat bleeding, or you treat the shock, oxygen, IV fluids, blood, and all that. You prepare for the cesarean delivery, and then probably maybe a hysterectomy will need to be done if that's necessary. You prepare the clients for emotional support, and you provide that support to the client and that of the relative or the partner. Then we have uterine inversion, where you have the uterus turning inside out. Okay. the uterus turning inside out after delivery of the baby. After delivery, at least you should have the uterus returning back to its normal position and then shape. But we have some instances where you could have the uterus rather turning inside out. It could be complete or partial. One of the risk factors or some of the risk factors is when you manual extraction of the placenta. That is why when we're doing the stage 3, I was telling you that you don't manually pull on the placenta to try to deliver the placenta. When you do that, you can cause what you call uterine inversion, or you can cause the uterus to turn inside out. When you also have some form of short umbilical cord, uterine atony. Atony is when you have the uterus not contracting enough after the delivery of the baby. At least the uterus has to contract adequately in order to help with expelling of the placenta in order to stop bleeding. But if you have uterine atony, you can cause all these issues or all these issues to occur. Then if you have some form of cancers or leiomyomas, then you have some form of abnormal adherent placenta tissues, all can lead to uterine inversion. When this happens, you will see a depression in the fundal area of the uterus will occur on assessment. You would also see the interior of the uterus. When you visualize or when you look through the cervix, you are likely going to see the inner part of the uterus, or you see it protruding through the vagina. Then you also have severe pain. Hemorrhage is also going to be there because at the end of the day, the uterus will also even not contract at all in order to help stop the bleeding. Then this client will show signs of bleeding. You monitor for hemorrhage. You treat it, as I've always been saying. Then you prepare the client for a return of the uterus manually back, or if that cannot be done, the client would need to be sent to the theater for a laparotomy to be done in order for the uterus to be sent back to its correct position. So this is what I'll talk about with the various issues that happens during labor and then delivery. If you have a question on some of the things that I've talked about, you can bring it on board before I try to see if we can talk about one or two questions, or we can go through one or two questions. And if we still have time, we will look at other areas as well. Like I said, by next week, Friday, I should be done with maths so that we can make progress to a different topic, okay, or a different system. Let's go through one or two questions if we don't have any questions from your input from me as well. But if you have any, kindly come on board with your questions. All right, let's see. So it says that the nurse is performing an assessment on the client who has just been told that a pregnancy test is positive. Which findings indicate that the client is at risk for preterm labor?
Oh, so you said
70.
Let's show more mute up my mind. This I'm going to answer my questions, no. Yeah, this who is here to answer the question. Someone should talk. I've been talking throughout. Someone should do also talk. Okay. Yeah, just tell me. Just say that 2. Then I know that you are going for 2. I've seen you guys going for 2 there. Okay. All right. All right, Priscilla Mensa. Priscilla, go
Yes,
ahead.
please. Please, I will choose answer 2. Because earlier when you were talking about risk factors for preterm labor, you made mention of cardiac issues, social issues, and also when the patient is younger than 18 years and older than 40 years and is the person's first pregnancy. So that eliminates 1 and 4. Wait, that eliminates 1 and 4, and then with 3, that is all. The hemoglobin level is within the normal range, so that leaves me with the option 2.
Okay. All right. Perfectly explained. Okay. So our sister has given us her rationale, then reasons for choosing that variant. See, that is one thing about them. When you are choosing your answers, ask yourself, why am I going for these interventions? Okay. I mean, ask yourself, are these reasonable interventions or reasonable options? Then, is it going to solve the problem the client is experiencing at the moment before you arrive at the answer? Unless is caring for a client at 30 weeks gestation who is admitted for preterm labor, sure the following intervention should the nurse anticipate it, etc. Administering IMB, methaxone, administering penicillin via IV piggyback, then assisting with artificial rupture of the membranes, initiating IV max sulfate, obtaining a fetal heart on 1 special. Okay. 1, 4. These are going for 4. As are going for 1, 2, 4. Okay. All right. Tell us your reason for going for the Madam Vivian.
Okay, so I will choose number 1. I am methaxone to mature the fetal lung.
Okay.
Number 2, no, because I've not
Okay. Go ahead.
seen anything concerning. It's not for number 2. So I also choose I will not choose 3 also because artificial rupture of membrane may put the woman to the risk of infection. So I also go for number 4, initiating IV magnesium sulfate, just to prolong the pregnancy.
Yeah.
And then, so I'll choose 1 and 4. 5 because they said 1 per shift, which is not the best.
Okay. All right.
Thank you.
Thank you too. So our sister is going for 1 and 4, and she has explained her rationale. What of you? I want someone else to talk. Let me see those who are answering. What options am I getting? 1, 2, 4. Okay, Kabiru.
Okay.
Kabiru.
Just, yes. Can you hear me now?
Yeah, I can hear you. Can you hear me?
Yes. Yes, I also choose question 1 and 4, and then with the same explanation. Then
Or
adding that, not choose 2. Yes, I'm just adding that, not choose 2 because uh, uh, there's no indication that there's a rupture of the membrane.
okay.
And then I also tell that penicillin is a teratogen.
Penicillin is a teratogenic. It's teratogenic. Is penicillin teratogenic? House.
No. Oh, no.
So it's 1, 2, 4. Okay. The reason for the penicillin is as a form of a prophylactic measure. Okay. So the penicillin is being given as a prophylactic measure to prevent infection in case there is a ruptured membrane and there's likelihood of infection. That is why the penicillin will be given. Okay, so the penicillin here will serve as a prophylactic measure, but penicillin is not it's not contraindicated in pregnancy. If you've done, oh, they have this thing. If the woman is having is syphilis and you have to give penicillin, and then the woman says, I don't take, well, I won't take the penicillin. We call it sensitization, or you have to sensitize the woman about the penicillin, and then you administer penicillin, okay, to the woman. Yeah. So the penicillin here is to serve as a prophylactic measure. So if you read the rationale, it says that administering antibiotic penicillin is to prevent group B streptococcus infection in the newborn if preterm birth occurs. Okay. So it will serve as a preventive measure, okay, in case there is any form of infection during the delivery. Yeah. So that is a nurse is participating in an obstetrical emergency simulation in which the healthcare provider announces shoulder dystocia. Which of the following interventions should the assisting nurse implement? Select all that apply. We have assist maternal pushing effort by applying fundal pressure during each contraction. 2, document the time the fetal head was born. 3, flex the client's legs back against the abdomen and then apply downward pressure above the symphysis pubis. Prepare the client for a forceps assisted birth. Request additional assistance from other nurses immediately. Yes. Who is also coming in? Some people go for 3-5, others go for 2-3-5. Okay. Madam Vivian, your hand is up.
Oh, so I want to go for 235. One, I will not go for one because under pressure, it can lead to rupture of the uterus if care is not taken. And then 2, I'll go for 2. Document the time the fetal head was born. And then number 3, as you talk about, reflex it. I'll go for 3-3. 4, tested delivery, no. Then 5. So 3-3-5.
Oh, okay. Okay, Abigail. That might be kindly unmute yourself and coming. Oh, Madam Abby, we are waiting for you. Thank you, Madam Vivian, for your rationale and then your inputs. As Madam Abby, have you dropped your hand?
Hello.
Yes, Madam Abby, can hear you.
I will go for 3 and 5 because we
Oh,
said that in the management of shoulder dystocia, we should
mhm,
use the Mark-Roberts maneuver and then
mhm,
apply downward pressure on the symphysis pubis of the mother,
mhm.
which will widen the birth canal, and then the dislodged shoulder will be out
Oh,
of the birth canal. And I
so,
chose 5 because it is an obstetric emergency, so we need help. So we have to
mhm,
call other nurses to come and help.
okay. So you are going for 3 and 5.
3 and 5, yeah.
Okay, thank you, Madam Abby. We have Sandra also on board. Sandra,
Hi.
yeah, go ahead.
Hi. I will also I'll add 4 to it because with the risk factor, we did talk about the suboptimal pelvic shape. So if you give assisted birth by forceps, that will also help because even if the patient is pushing and the baby's the woman's pelvic shape does not support the baby size, they usually give forceps delivery. So I'll go for 2, 3, and 4 and 5. Yeah.
4. So go for 2, 3, 4,
So
5.
yeah.
Okay.
Thank you.
All right, thank you. All right. Is that all? Or we still have someone whose hands is up? Okay. Okay, so let's see our final answer. So it's 2, 3, 5. Okay. Of course, you need to document. So I was curious about, was it Madam Vivian who took the documentation out? So Liz, you need to document when the time the fetal head was delivered. For the assisted, the forceps assisted birth is a no-go area here. So fundal pressure and the use of forceps or a vacuum to facilitate the birth are contraindicated here. Okay, we don't do that. Okay, so
Is
see
it
the
in
one.
Ghana or everywhere? Because see, yeah, in UK they do it like it's often, especially with Filipino women, like they are short and their pelvic is quite small. So they are not able to, most of them are unable to deliver normally. So if they start vaginal delivery and they need assistance, they will do the forceps delivery before. If it fails, then they'll do an emergency CS. That's why I chose that one. But then if it's not done, it's
So
fine.
for the purpose of parenting,
Oh, ankles. Okay, thank
we
you.
don't do that. You have to try the macrovert maneuver in the instance of when there is shoulder dystocia. Then you can, if that fails, before you can maybe send the woman in for cesarean birth to also done. So,
Thank you.
yeah, Madam Vivian, your hand is still up.
Yes, so sorry, I'm using phone, so I didn't even see the number 5. The question 5, I didn't even see it at all. So
I
sorry.
did the option 5.
Yeah, I didn't even see it at all.
Oh, okay, okay.
Okay.
All right. Following the precipitous birth of a term newborn, what is the best action by the nurse whilst awaiting expulsion of the placenta and arrival of the healthcare provider? 1, clean the perineal area. 2, gently pull on the cord. 3, keep the infant warm. 4, massage the uterus. Sorry, the fundus. Sorry, massage the fundus. what do we do in this instant? What be the best action here? Okay. If you have a woman following a precipitous birth of a term baby or a term newborn, after delivering of the baby, what is the next best action, or what is the next best action whilst awaiting the expulsion of the placenta? Cleaning the perineal area, gently pulling on the cord, keeping the infant warm, massage the fundus. All right. Yes, who is talking? I can see your answers still. 3, 4, 3, 4, 3, 4. I'm interested in the 3, 4 options. Okay, those of us going for the 4. Tell me why. Those going for the 3, to tell me your reason. Or you want to keep your rationale to yourself. Oh, so no one is ready to talk. Okay, let me call those who answered. Madam Anastasia, you went for option 3, Homsen. Why did you go for 3? Mr. Kabiru, you also went for 4. Why 4?
Okay, this Anastasia.
Oh,
Okay, after delivering the baby, clean the baby and you keep the baby warm and maybe try to put the baby to the breast while maybe the assistant, or when the baby is okay, then you can come and take care of massaging of the fundus and probably delivery of the placenta.
So your best action will still be which one? Keeping the baby warm.
Warm, yes.
Okay. All right. Thank you. Someone says 4 helps the placenta to detach. Okay. All right. So it's 3. Okay. Yeah, the best action over here is to keep the infants warm. Okay. The fundal massage is performed after the placenta is delivered to increase uterine tone and then decrease bleeding. Okay. So it is only after the delivery of the placenta that is when you do your massaging of the fundus to help with contraction and then prevents bleeding and to ensure that the uterus become firm. And then and then remain in the midline position. All right. Let me see. Let me see something. So that is the answer is the 3. I want to check on something to see if I will still continue or I have to do something else. Let me see. Okay. I think I can do this in our next meeting. And that will be all for this. So I left with some few things. We'll talk about it in our next meeting, and I can use one day to finish that. So let me end here for today, or we still have some questions we can do, 1 or 2 before we drop it. On Friday, when we may go willing, we'll finish maternity, and then probably maybe on Saturday, maybe we'll do something else and then we'll take it up from there. But let me see. I think I can do 1 or 2 questions with you, then I drop it there. Okay. No, not here. All right. Ooh, okay. I think here. We are here. Okay, we are here. Let's do this last one. There we go. Okay, we answered this. A client who is a gravida 4/3 at 38-week gestation arrives in the emergency department with strong contractions that begin 1 hour ago. The client is diaphoretic, grunting and yelling loudly that she wants an epidural because she feels the need to push. What priority action should the nurse take? 1. Apply gloves and assess perineal area. 2. Initiate large bore IV access. 3. Notify anesthesia provider of client's request for epidural. Obtain a fetal heart tone via a Doppler. Ooh. Okay. Yeah, Madam Vivian.
Okay. So I'll choose 1. Apply gloves and assess perineal area, because the questions is the client the client is diaphoretic, is grunting and yelling loudly that she wants an epidural because she feels the need to push. So maybe head in perineum. So you need to assess first before any other thing. So I'll choose 1.
Okay. I think it's quite straightforward. This tells you that this woman is probably having a precipitous labor. Looking at the time the woman presented with labor and the time the woman is telling you that she wants to push and all that. So at least you need to do your vaginal examination to assess to see if indeed the baby is coming or the presented part is there, then you deliver the baby. So that is it for today. I'll end it here. Friday we'll complete this topic as I said, and then we will see what we will do next as well after that. So thank you for coming. Thank you for staying. If you have a question, you have an input you want to make, or you have a clarification you want to seek based on what has been discussed, you can bring it on board as well before I drop the class here for today.